We'll start off here with a very warm good morning on a brisk day here in Washington, D.C. Welcome to the first day of the public witness hearings on tribal government under the jurisdiction of the Interior Environment Appropriations Subcommittee. And I always look forward to this time of year as it provides us, all of us here, to see and hear from leaders, mentors, and in many cases, friends over the years, as you testify about the needs of Indian country and what work we need to do here in Congress. This year in Congress, we've had some new additions in elections. So we're very excited with the Native American caucus with Tom Cole and Congresswoman Deb Hadlin leading that, along with Congresswoman Sharice Davis being part of the Native American caucus. I have a new title now with my gray hair as Chair Emeritus, and I'm very happy to have my two tribally enrolled sisters overtake the leadership of that committee. So they have been given copies of the testimony. We're in constant contact. They're on other committee assignments, and so I'm just, as you know, very pleased about that. But I'm pleased that you're here, distinguished leaders and that are elected and non-elected tribal leaders, because you play such an important role in advancing Native issues. This year, in hopes of having a more in-depth focus on issues facing Indian country, we've organized this a little differently. We organized it into topics: healthcare, land trust, natural resource management, including climate change, public safety and justice, education, tribal government, and human services needs. Now, this is the first time the subcommittee will be holding hearings organized by topics. And we want to hear your feedback on how this works once the hearings have concluded. But this came in part because we had tribes coming and by geography and trying to figure that they hit every single topic. And then when issues of suicide or criminal justice came up, we weren't able to really feel that we could ask questions and keep something flowing. So we do want your feedback on this, as this is your hearing. So let us know what changes or accommodations we need to make next year. We'll begin hearing from witnesses on healthcare needs that are facing Native Americans. The federal government entered into guaranteeing health care with their treaties to our Native American brothers and sisters. And my visit to tribal communities across the nations have shown me just how we are failing, and failing greatly at meeting our treaty responsibilities. Congress must not take our treaty and trust responsibilities lightly. Congress needs to figure out how we can best fulfill our duty, given the limited funds that we have to work with, and how to make those funds grow and work more effectively for you. In the recent month-long Trump shutdown, this issue was even made more urgent as healthcare facilities were closed to scale back services, thus impacting those who need healthcare the most. The shutdown illustrated the importance of providing funds to Indian country in some form of advance. And that's why I'm pleased to be leading a bipartisan bill in the House to authorize advanced appropriations for the Indian Health Services and the Bureau of Indian Affairs. And Mr. Cole and I are on each other's bills complementary. He's been working along with some other people about mandatory funding. So as we figure out together how to fully meet the needs of Native Americans, I believe the least we can do is provide some certainty to lessen the impacts should there be another shutdown. We're all hoping that there isn't. I'm eager to hear more about your priorities, and I look forward to our discussions on these issues, because your testimony is going to inform us as we begin working together on the 2020 appropriations bill. Now, Mr. Joyce and I are going to kind of just go over the hearing logistics, and then I'm going to turn the meeting over to him for some topics. We're going to have the panels of witnesses. The first panel is up here, one panel at a time. Each witness will have 5 minutes to present their testimony, and we're going to use a tracker because we want to be fair to everyone to track the time. When the light turns yellow, the witnesses have 1 minute remaining to conclude their remarks. When the light blinks red, I'm going to lightly tap, and I really ask you to conclude your remarks so that our next witness can begin and everybody has equal time in which to present their testimony. We have your full written statements, and they will be introduced to the record. And so please do not feel pressure to cover everything. I've read all the testimony for today, and I have it all marked up. So believe me, if we don't get to your question, we're going to get back to you with more questions. So I'd like to remind people in the hearing room that we prohibit the use of cameras and audio equipment during the hearing by individuals without a House-issued press credential or a staff ID. And as I mentioned, members will be coming to and from. Mr. Kilmer, I told him I saw you running through the Capitol earlier today. So when this meeting concludes, we will adjourn and we will reconvene at 1 o'clock for the afternoon hearings. So I'm happy to yield to my friend and colleague, Mr. Joyce, for his remarks.
Thank you, Madam Chair, and thank you for continuing these important hearings to get input from our tribal leaders on a wide array of programs under this subcommittee's jurisdiction. I'd like to extend a warm welcome to the distinguished tribal elders and leaders that are testifying today and in the audience. I'm humbled to be sitting here before you today in my capacity as ranking member of the House Appropriations Subcommittee on Interior, Environment, and Related Agencies. I know that most of you have traveled a long way to be here this week. I'm from the northeast corner of what is now Ohio, but was once the land of Seneca and others. Like many colleagues in Congress, I recognize that upholding the tribal trust obligation is a responsibility shared by all members of Congress, regardless of the congressional district. I also recognize that the federal government still has a long way to go before it can, that is fully meeting its trust and treaty obligations. That's why my position on the Appropriations Committee is a great honor, but also a heavy responsibility. Fortunately, I have a great friend and partner in Chairwoman McCollum, and it's my sincere hope that together we will continue the hard work of our predecessors for more than a decade to increase the federal commitment to meeting those trust and treaty obligations. I so look forward to listening and learning from the testimony today and working with my chair and the rest of my colleagues in the days ahead to do what we can in the next fiscal year, and I yield back.
Well said, Mr. Joyce. We work on this nonpartisanly, not even bipartisanly, when it comes to Native American issues. Mr. Kilmer, any opening remarks? Mr. Simpson?
No.
Well, we have our first panel up here. We have the National Council of Urban Indian Health, Urban Indian Health Institute, the Northwest Portland Board Area Indian Health Board, and the Seattle Indian Health Board. So if you would please, at the beginning of your testimony, introduce yourself and your organization. And let's start with the National Council of Urban Indian Health, please.
Good morning. My name is Maureen Rosette, and I am a citizen of the Chippewa Cree Nation in Rocky Boy, Montana. I'm also the president of the National Council of Urban Indian Health, which represents 42 urban Indian health programs across the country who provide high-quality, culturally competent care to urban Indians, who constitute up to 70 to 78% of all American Indian Alaska Natives. Thank you to the chair and ranking member for holding this public witness hearing, and hope this year is the year we will truly see funding level changes. My testimony today will mainly focus on the Indian health services. I first mentioned the urban Indian topic. That term refers to any American Indian Alaska Native who's not living on the reservation, either permanently or temporarily for a variety of reasons, but often because of the federal government's forced relocation policies or in search of economic and educational opportunities. Congress has long recognized that the federal government's obligation to provide health care for American Indian Alaska Native people follows them off the reservation. Recently, CMS, Center for Medicare and Medicaid Services, made a decision regarding the Arizona 1115 waiver to use the narrowest definition possible of American Indian Alaska Native for Medicaid work requirements. This is despite the fact that Congress stated that the purpose of the Indian Healthcare Improvement Act was to ensure the highest possible health status for Indians and urban Indians and to provide all necessary resources to effect that policy. CMS ignored centuries of law and extremely narrowed the American Indian Alaska Native definition, which will hinder access to care across the country and further burden an already overwhelmed and underfunded Indian health service system. I'd like to start by thanking you and offering my deep appreciation for the subcommittee's strong leadership and continued support for Indian health care. NCUI has several recommendations for the FY20. One is to increase the urban Indian line item for IHS. Less than 1% of the IHS budget is set aside for urban Indians who are urban Indian programs. And as you may or may not know, there's up to 70% of all American Indian Alaska Natives are urban. Urban Indian health programs do not have access to other items throughout the IHS budget. The 42 urban Indian health programs operate with 1% of IHS budget funding, which is approximately $51.3 million. Thank you for the $2 million increase in our line item. However, we do not believe that the solution is to take money from the tribes to address the unmet need of urban Indians. Rather, IHS's overall budget must be increased in order to allow the agency to, among other things, better serve American Indian and Alaskan Native people who live in all areas. Tribes have requested our line item to increase to $81 million, which we are eternally grateful for. We would request that the IHS budget increase our line item to at least 2%, which would be about $116 million. While this is just a sliver of the money Congress appropriates yearly, it would make a significant difference in our communities. Presently, urban Indian health programs and their staff are forced to deal with incredibly tight budgets. In this last shutdown, 2 of our programs had to completely shut down. 3 of them had to reduce hours as well as lay off staff. 6 programs had reported that they would only be able to stay open for an additional 30 days. Our UIHPs go to great lengths to provide care in Indian country. Some have even had to take in personal liens on their homes to assist with their facilities. Congress cannot continue to let this happen and must create true parity for urban Indian health programs. We have a program in Minneapolis, Minnesota, for instance, where we have a homeless crisis for American Indian Alaskan Native people, many of whom suffer from diseases, addiction, and other serious health complications associated with homelessness. Increased funding is needed to combat the senseless deaths of vulnerable urban Indian communities. Our programs are in need of real funding to tackle these very real issues. In addition, IHS is considering moving its behavioral health initiatives from grants to direct distribution through the Indian Self-Determination Education and Assistance Act contracts and compacts, for which UIHP's urban Indian health programs are not eligible. Urban Indian organizations currently only receive $5.9 million in these grants, which fund vital behavioral health services. As a whole, by inadequately funding IHS, Congress has put the federal government in clear violation of the trust responsibility to provide health care to all American and Alaskan Native people. We know the lawmakers on this subcommittee have fought for more IHS funding, and NACUI wishes to express our profound thanks for those efforts. We'd also like to protect IHS from funding uncertainties. As I stated more than once, UIHPs are their funding for UIHPs are severely limited. When that funding is delayed or cut off in the event of funding uncertainties such as government shutdowns, UIHPs suffer greatly. It is for this reason IHS and Indian health programs must receive advance appropriations. According to the survey of UIHPs and the rising frequency of shutdowns and funding delays, many of UIHPs have begun to set aside funding in the event of a further shutdown. This is funding that we actually need for our programs, which we shouldn't have to worry about further shutdowns. We also would like to recommend that.
I have to.
Okay.
Thank you.
All right, thank you.
Thank you. Ms. Zackelhag.
Good morning, and I want to thank you, Madam Chair and Ranking Member Joyce, and also acknowledge Representative Kilmer, who has had such strong support of our organization in Washington, both our urban Indians and our tribes. Thank you for this opportunity to speak with you. My name is Abigail Echohawk. I'm a citizen of the Pawnee Nation of Oklahoma, and I am the Chief Research Officer at the Seattle Indian Health Board. In that role, I direct the Urban Indian Health Institute, which is one of 12 tribal epidemiology centers located across the United States. The tribal epidemiology centers are tasked with ensuring that the health needs and the health resiliencies of American Indians and Alaska Natives are represented through evaluation, data collection, and research. This was an effort that was driven by tribal leadership, and we are directed by tribal leaders for our tribal nations. We fulfill a very unique need here in the country because often when we talk about research and data, what we hear is that we don't have data. This information does exist. All you have is a few individual stories, but we need the data in order to make these informed decisions. It is our role to ensure that our tribal communities and our urban Indian communities have this information. However, we are woefully underfunded. And in fact, I am directed to use the $341 approximately that is given across all of the 12 tribal epidemiology centers to cover more than 70% of the population. And that's because the Urban Indian Health Institute represents the needs of all urban Indians living across the country. I specifically serve the organizations that Maureen represents, along with more than 20 others that provide social services, elder care, diabetes care, and youth services of more than 62 organizations in 28 states and more than 130 different counties across the United States with less than $400,000. What does this mean? When we talk about evidence-based practices and the practices that we are supposed to implement within our tribal clinics, the evidence that is gathered for these practices don't actually represent us. So when research is done, American Indians and Alaska Natives are very rarely included. So practices that we're supposed to do in diabetes management, in preventing cancer, in obesity, those practices actually don't have our evidence in them. And if they were going to work, they would have worked by now. So we are forcing these interventions that were never meant for our people, yet that's what we're being asked by the government and the states and our counties to implement with our people. That is the reason organizations like the Urban Indian Health Institute and the Tribal Epidemiology Centers are so important to the work that we do. We answer to the needs of our community, and very often we do that underfunded. I want to share with you two particular things that we've been doing at the Urban Indian Health Institute, one on sexual violence. We released a report in Seattle that talked to 148 Native women living in that city who had been affected by sexual violence, and what we found was a 94% victimization rate. That means 94% of these women had been sexually assaulted in their lifetime, and more than half of them had been sexually assaulted more than once in their lifetime. Along with that, what we found were corresponding health issues such as suicidality. More than 42% of them had attempted suicide in their lifetime. High instances of alcohol misuse and opiate misuse. We are not battling an opiate epidemic, we are battling a trauma epidemic. And if we were to take away all the opiates, people would treat themselves with heroin, with methamphetamines, with alcohol. What it takes is research like the work that we are doing at the Urban Indian Health Institute. In my personal opinion, I believe our study is one of the very first ones that actually found the correct rates of sexual violence within our communities. There are stories of where our women sit around and we don't talk about how do we prevent our women from being raped. We talk about what do we do after they are raped. That is the conversation our communities are having. And yet this data for the very first time is coming out of a little organization that had no money, and we self-funded that project in order to bring those to light. And in fact, when we look at VAWA dollars, none of the VAWA dollars flow to organizations like the Seattle Indian Health Board because they go to the counties. And so we are not actually getting dollars to provide culturally attuned care to our women who are victims of sexual assault and domestic violence. And so that is one of the instances of how those dollars aren't reaching the urban Indian communities. In addition, we've been doing work on missing and murdered Indigenous women. We conducted the very first study on 71 cities across the United States, and we found high instances of missing and murdered Native women. And in fact, our communities have been calling for a study like this to be done. The Department of Justice and the FBI said that it couldn't be done, that it would take too much money. I did it with less than $20,000 that, again, self-funded out of our organization, and we created a groundbreaking study that is the very first of its kind. What I found, though, is I can't tell you the rate of missing and murdered Indigenous women, and that's because the police departments aren't collecting race and ethnicity. We found police departments that weren't collecting it at all, or if their police did not collect it, they automatically default you to white within their data systems. What's interesting about both of these studies is they were led by Indigenous students that we support. Here at the Seattle Indian Health Board and the Urban Indian Health Institute, we are building tribal health capacity by supporting students and doing this work unfunded. It is a necessary thing for public safety for us to continue to address these issues and its impact on health in our women and our communities. Thank you.
Thank you very much. Mr. Joseph?
Good morning, Chairman McCollum and Ranking Member Joyce and members of the subcommittee. You Hootkini squeezed Badgers, my name. I'm Andy Joseph Jr., the Vice Chair of the Calva Confederated Tribes and the Chair of the Northwest Portland Indian Health Board. Thank you for this opportunity to highlight some of the recommendations I have made in my written testimony. As a tribal leader committed to advocating for health care of our people, I make these requests for our seventh generations and ancestors and our chiefs who signed treaties with the United States and sacrificed land, resources, and more than I can imagine. What I can imagine is that someday I will come before the Creator and the chiefs, and they will ask me if I asked for everything that we were promised. And I will tell them, yes, I asked for everything. So I ask the subcommittee to consider these promises binding legal obligations, and our chiefs, they upheld their end of the deal, and so must the United States and this Congress. With this in mind, I make these requests. We ask the subcommittee to commit to full funding for IHS. I serve as the Portland area representative and co-chair of the National Budget Formulation Work Group. I recommend that the subcommittee fully fund IHS phased over 12 years to get IHS up to $36.8 billion. We request that IHS be funded at $7 billion in FY 2020 with annual increases thereafter, and get IHS up to full funding. The fundamental budget principle for the Northwest Tribes is that the basic health care program must be preserved by Congress, which can be done by ensuring that population growth and medical inflation for current services are always funded, and that program increases occur annually. I have said this before, and others before me. IHS is between 50 to 70% underfunded, and this must change. In FY 2019, IHS received an overall increase of $162 million, or 3.4% above FY 2018 enacted level for program and services, not including the increase for mandatory contract support costs of $104 million. We estimate medical inflation and population growth for FY 2019 at $268 million, and with only $162 million increase for program services, there was a $106 million shortfall. We are concerned with that in the FY 2018 programmatic funding. The Indian Self-Determination and Educational Assistance Act 105L leases were funded at $25 million in FY 2018 and estimated at $39 million in 2019. Well, we agree that tribes should be funded for these leases, and annual funds must be appropriated. Additional funds must be appropriated for this purpose and not taken out of increases for IHS and tribal facilities. With no IHS, our tribal hospitals in the Portland area, Northwest Tribes rely on PRC program to purchase all specialty inpatient care. PRC increases have been inundated or inadequate for Northwest Tribes, and particularly detrimental because of flat funding in FY 2016. More tribes would benefit from increased PRC than the appropriation to Indian Healthcare Improvement Funds for FY 2020. We recommend a PRC program increase of at least $50 million. Another area of great need is behavioral health. The Special Behavioral Health Pilot Program was funded at $10 million in FY 2019. Northwest Tribes support the pilot. However, Northwest Tribes recommend the option for tribal shares instead of grant awards for FY 2020. We recommend that the Special Behavior Pilot Program for Indians be funded at $150 million with an option for tribal shares, and an additional $5 million made available to area boards, tribal epidemiology centers, and technical assistance to tribes. Northwest Tribes do not support funding for new health care facilities construction until the IHS priority system is changed. The Northwest Tribes would not see any of this funding for at least 20 years from now. Instead, for FY 2020, we recommend a program increase of $25 million for small ambulatory programs with funding for staffing packages, increases for joint venture construction programs. In the past few years, the Northwest tribes have been forefront training placed dental health aid therapists, Oregon, Washington, with more students graduating this year, including from Idaho. I guess I'll answer any questions when they get done. Do you have my written testimony? And thank you for this opportunity.
Thank you, Mr. Chairman. There is so much to say, and that's why we organized to do a healthcare panel so we can dig into it deep this morning. Please.
Hi. Good morning, Madam Chair. It's wonderful to see you. Ranking Member Joyce, I'm meeting you for the first time. Representative Kilmer, I think I missed you yesterday, but I'm happy to see you today. And Representative Simpson, I've never met you, so I'm happy to meet you today. My name is Esther Lucero, and I am the CEO for the Seattle Indian Health Board. I am Dene on my mom's side, and I'm Latina on my dad's side, and I am third generation in my family to live in an urban environment. So quite frankly, my entire life experience has been in an urban environment. The Seattle Indian Health Board is an urban Indian health program funded obviously through the IHS, and we're also a federally qualified health center, and that means that we see everybody. And despite the fact that we're smack in the middle of Seattle, we still maintain a patient population that stays between about 65 and 70% American Indian and Alaskan Native. One of the things that's unique about us, you met Abigail Echohawk, whom I'm incredibly proud of, and through her leadership on the work related to missing and murdered Indigenous women, we have the Urban Indian Health Institute. And so I wanted to build upon what Abigail just said, and I wanted to let you know that we are funded, the Urban Indian Health Institute is funded through IHS for just under $400,000 a year. So keep that in perspective, right? We have 12 tribal epicenters across the nation, and we are asking for a $24 million line item ask to support the tribal techs. If you break that down, that's about $2 million per tribal epicenter. That will allow us to build upon this work related to missing and murdered Indigenous women, not just for us, but also for our tribal partners. You know, I'm incredibly privileged to be in the state of Washington where we have leaders like Andy Joseph that I can learn from every single day. And so I want to remind everybody that we are a continuum of care, right? And so when I think about our tribal partners, we pick up where our tribal partners leave off in the urban environments, and we support our tribal members, right? So I just wanted to say that we've had incredible growth this year, and Representative McCollum, I think you'll be really happy to hear that in addition to our family medicine residency practice, we've actually built out an MSW practicum program because we're treating these disciplines with parity. Well, the other discipline we're treating with parity is traditional Indian medicine. So we actually built out a traditional Indian medicine apprentice program. And I will tell you that we've had our encounters increased from 150 encounters for traditional Indian medicine per month to 800 encounters per month. We've also been successful in securing a managed care organization who's agreed to pay for traditional Indian medicine as a value-added benefit. I share this with you because the Seattle Indian Health Board, for the very first time, is building out an integrated system of care that is not only inclusive of behavioral health and primary care, but also is centered on traditional Indian medicine. And our new model incorporates dental as well. And we've mobilized our human services so that they can be on call to support those service needs when it comes to homelessness, like Maureen mentioned. And so we're very proud of that. It's called Indigenous Knowledge-Informed Systems of Care. It's a strength-based model. Now, I'm sharing that with you because we are asking for a $95 million line item increase for the urban Indian health programs. We're grateful that there was a $60 million recommendation out of this committee. I mean, you all are rock stars when it comes to supporting us. However, when it got to the Senate, we ended up with about $2 million, right? So we're asking for continued effort to increase that line item. Now, when we are trying to implement new systems that are integrated, innovative systems, we have to address infrastructure needs, right? So we have to change our data systems so that they can speak to one another. We have to address facilities changes because it's very hard to build out an empanelment system with these old buildings that we've had since the 1970s. And so if we're going to put these teams of practitioners together, we have to redesign. and we need support with that. So we are modeling ourselves after the aggressive approach that we're taking through the Northwest Portland Indian Health Board and the leadership of our tribes, and we're increasing that to ask you to invest in infrastructure. Urban Indian health programs have never had the ability to do that. Now, I know this is possible because HRSA actually did it this year. For the very first time, HRSA, through a mental health expansion grant, included infrastructure dollars. I was surprised to see it, but also excited. So let's think about that as a model, right? So I will just share that with you, that we're still continuing to fight for 100% FMAP. And someday I won't have to say that. But today I'm saying it. I'm saying it because in the state of Washington, through the leadership of the American Indian Health Commission, we've been able to develop an innovative bill. So we have a Washington Indian Healthcare Improvement Bill that's in the state right now, moving through committee through the leadership of Andy Joseph and others, where we are asking the state of Washington to reinvest the 100% FMAP dollars into the ITU system of care. Okay, we can only do that because our tribal members recognize our value. And they've said, let's bring our urbans along with us, right? Not because urban Indians are eligible for the 100% FMAP. We are asking for 100% FMAP for urban Indian health programs. So I think that if now that states have more authority over healthcare, if we can come up with innovative requirements like that, we can do better. And then lastly, I will just say that we support the tribal request for advanced appropriations. Yeah, let me tell you why. Because the shutdown gave me some gray hair this year.
I'm sure you'll probably get a question on that, but
Okay,
I
let's
have
do
to
that.
be.
Oh, you have to stop me.
I have to be as judicious as possible.
This is the
and as polite as possible.
Yes, of
especially
course.
when we are so wanting to hear from all of you.
Right,
It's,
right.
it's hard.
This
it's
is the
hard,
first
but
time I've gone over, and so thank you for stopping me.
It's all it's all good. Mr. Kilmer?
Thank you, Madam Chair, and I want to say thank you for the work that's been done shining a light on the crisis of missing and murdered Indigenous women and girls. I thought it was devastating to see that Washington State had the second highest number of instances. Both Seattle and Tacoma were in the top 5 cities. And I know we're short on time, so I guess my main request would be just to hear how Congress can work with you to make sure you're getting the data that you need, that this issue is getting the attention that it needs, and then hopefully that you're getting the resources you need to address it.
So one of the areas that we're working on, there's opportunities right now going on with Savannah's Act. We are part of a tribal coalition that is working towards ensuring that there are no as many unintended consequences with what's going on with Savannah's Act, but it also does look at what kind of information and data is being gathered. In addition to that, there needs to be further cooperation between both the police departments and the Department of Justice and the FBI. When we look at the urban settings, very often people don't understand that we're not talking about the tribes with the work that I did. And the tribes have a unique relationship with the Department of Justice and the FBI, and they're not getting the information either. We're in these cities being served by police departments. Many of the police departments, actually, it was approximately 17% never responded to our public records request, so they never actually sent us the money. I'm sorry. I gave some of them money, and they didn't send us the data. And so I actually paid some of them, and they never sent us the information. And so accountability for them to respond to the public, in addition to, why aren't they mandated in the same way we are in healthcare to collect race and ethnicity? Because they don't know what's happening with missing and murdered people. How can they protect and serve their communities if they're not doing so? So there's opportunities at the federal level to look at the way that dollars are flowing into counties, into states, into police departments to ensure accountability. And we are more than willing to provide feedback and work with our tribal coalitions to ensure that that's happening in Savannah's Act and also with other pieces of legislation to ensure that accountability.
Thank you. Thanks, Madam Chair. No, thank you.
Mr. Joyce?
Ms. Sacco-Hawk, did I hear you correctly that
We want to hear you, so we're going to turn
Oh.
you right.
do I hear you correctly in the law enforcement community has not provided you the data under a public records request?
Correct. So it was, I'm remembering offhand, but I believe it's approximately 16 to 17% of those that we asked for it did not provide that to us. Some of them, for example, we've actually heard from the Portland Police Department is one that we paid, that some of them required payment. So
Why are you paying?
That was our question too. Often within their states, if it did what they called an undue burden on their police departments, we were then required to pay for the data. I actually was asked to pay for more than one. I'd request for more than $4,600 where I could have gotten more data, and I couldn't afford it because I self-funded this project. And so I would have had more data if I'd had $4,600. For the states that didn't reply, for example, in Billings, Montana, the chief of police actually accused us of lying, that we hadn't actually sent the public records request. Luckily, we used a service where we screenshot it, sent it to him and also the records, and we had no response after that from the Billings Police Department in Billings, Montana. And so there is non-compliance from not many, but some of these police departments with public records requests.
But you shouldn't be paying for anything unless you're asking them to create data that they're not keeping as a public record, correct?
Correct.
So this is
That is
stuff
one
that's
of the
already
issues.
kept by them, and the only cost they can charge you would be the cost per copy.
Right.
Which really isn't a cost per copy, since they're gonna give it to you in e-format anyhow, correct?
Exactly. So, for example, in Alaska, we asked for records prior to 2013, and they hadn't digitized their records prior to 2013. So they weren't able to give us that information, but they're working towards giving us 2013 forward. But there is, it really depends state to state. There are some state laws that allow them to charge if it is an undue burden to them and that's really dependent on each individual department as to what they constitute an undue burden.
Well, an undue burden would be when they have to take and extrapolate from the data they've already collected certain things just specific for you. But if you're getting public records, maybe that's something the local newspapers should look into. They're always pretty good about jostling police departments.
I agree. And many newspapers actually replicated, because they were able to see what our public records request was, they replicated that because they wanted to also look at the data and information. So there is news coverage on that. But also, to me, it's an area of accountability. Why is it so hard for us to get these public records? We are members of the public. And in its very
records.
definition, there are records.
Right, absolutely. Thank you.
Mr. Simpson?
No specific questions. More water. I'm just wondering, Abigail, are you any relation to Larry?
Yes, that's my uncle.
Ah, good friend of mine. We served together in the Idaho legislature, and was a great director of BIA. And he went on a couple Codells with us to South Dakota and Oklahoma and other places. And yeah, he's a great guy.
Yeah, I'm very fortunate.
Yeah. Thank you all for being here today and for your information.
Yes, thank you.
Might I say one more thing? I co-chair the IHS National Budget, and the PRC that I talked about was low funded in 2016, and it's been, based on numbers. If we keep going backwards, we're going to be back into the life or limb priority 1 situation with IHS again. I just really urge you to look at increasing the PRC. It would help every area, not just the Portland area. I don't want to get back into priority 1 status.
Agreed. I save myself for last. I'm trying to do things a little differently on the committee, especially when we're in these wonderful settings where we're hearing directly from you. One of the things that I'm hearing and read throughout the testimony is this issue of grants versus direct funding. So if we don't do grants, do you have, and you don't have to answer this today, you can get back to me through your health. If we start going to formula, then sometimes it's based on per capita. And per capita works, and then sometimes it doesn't work, depending upon the dollars that are there. If you do it by per capita, then some smaller tribal organizations will just find themselves left out, whereas competitive grants kind of gives everybody co-equal. So this is something I'm going to ask you to talk amongst yourselves and come to us with proposals. I don't want to just assume that I know what will work best, because we don't want to leave anyone behind. And you, better than anyone else, I think, exemplify groups that because you don't have all the specific line items, many in your urban healthcare settings. So if you could help me with that. The whole issue about murder and Indigenous women, First Nations in Canada, Canada's been working on it. The Northern Tribal areas have been working on this. I know Minnesota's just under the leadership of our Lieutenant Governor Peggy Flanagan, and we have several Native American women who serve in our state legislature are taking a great lead on this. So this is in the Department of Justice, and in reading the testimony again and hearing you over the years, many of the things that happen in the Department of Justice, the way that they're handled, impact how health care is provided later on. So it is something I'm going to sit down and talk to my counterpart with, maybe with Mr. Joyce. We can talk to the ranking member and the chair about how one thing impacts the other and see if we can talk to them about what to do. Mr. Cole and I worked hard to get the 5% set aside. That was a victory, but there's still more work to be done. So any conversations that you have with our colleagues maybe also need to include the appropriation members on the judiciary who fund judiciary. The opioids dollars, shocking. You were not able as organizations to apply for the opioid dollars. SAMHSA did not have enough applications submitted to them. This is another thing where the grants program kind of failed. Dollars were left on the table. So my question is, do you know exactly what we need to do in the opioids to fix this? And if so, tell us right now, and we'll talk to the authorizers.
I can speak to this. So we've been speaking with many administrative bodies. When you put out the RFAs, you have to explicitly state that urban Indian health programs are eligible. Because what happens is, oftentimes, it says tribes and tribal organizations, and the assumptions within the administration, the administrative bodies, is that we are, quote unquote, a tribal organization, but that is a specific designation that we don't fall into. So it has to explicitly state urban Indian health programs.
Okay, so we need to see if it's statute, rule, or whatever.
Exactly.
We are on it.
Thank you.
We're on it. The special diabetes program has been, that Mr. Simpson and I saw had been, culturally moved forward. Mm-hmm. You've talked about some of the things that you are doing. Is there anything that's prohibiting you from doing more culturally oriented things besides space and
Yes. Well, I mean, I have to tell you, it's our IHS dollars that allows us to maintain our cultural integrity. So it funds our entire traditional Indian medicine program. So that is why we consistently ask for an increase in our IHS funding, because until we get a system that allows us to be self-sustaining, we need that money.
So when you're in an urban setting versus on a reservation, is it more challenging to come up with culturally appropriate? Because what Mr. Simpson and I saw were people going out fishing and harvesting the rice and all that. So it's more challenging for you to do it, yes or no? Or
well,
that's not a fair question, I'm not sure.
Well, let me answer it this way. So we serve representatives from more than 250 federally recognized tribes. So we have to have more diversity in the ways that we provide traditional Indian medicine and cultural programs. And so, yes, it makes it a little bit harder, I believe, for us. We're building out a network of traditional Indian medicine practitioners so that we can cover as many regions as possible, and that takes resources, right? So, yes, but I wouldn't say, again, I always stay away from this idea that tribes somehow have it harder or urbans have it harder, because we are the same. We're a continuum of care. We need to support the whole, right? It's just our needs are sometimes different.
Okay, well, I let everybody go 30 seconds over. Mr. Joseph, because my grandmother would be very disappointed if I didn't respect an elder at the table. I'll give you another 30 seconds if you want to add something.
I've been, I'll just use myself as an example on traditional medicines and healing. I cleaned my great-great-grandmother's grave. She lived to be 118 years old, and she ate our traditional foods and medicines and the work that it takes to gather it. I've included that in my diet for my evening meal. what do they call it? I went from being severely obese. Now I'm right there at the edge of not being obese in 2 months' time. But one of the things that we're dealing with is the Federal Tort Claims Act also is hindering some of our traditional practices because they're not really respecting our sovereignty to be able to treat ourselves in a traditional way, not only with our nutrition but with mental health. And I co-chair the SAMHSA TTAC as well, and we've been working on trying to get them to use traditional practices. The VA does. They have a sweat house behind our VA hospital, so it works.
Thank you, sir. Thank you so very much. Mr. Joyce, would you like to introduce the next panel? The next panel, if you'd please come forward. Good morning.
Well, thank you all for being here today. In case you weren't here initially, we obviously have a panel in order. It will give each of you 5 minutes, and then we'll take questions at the end, starting with Dr. LeBeau.
Okay, well, thank you. Good morning, Chair and committee members. My name is Mark LeBeau. I'm the Chief Executive Officer of the California Rural Indian Health Board, or CRIB for short. Thank you for providing me the opportunity to testify about funding and other needs of the Indian Health Service Agency and tribal health programs in California. CRIB was established in 1969 and provides comprehensive healthcare-related support to 16 tribal health programs sanctioned by 45 tribes serving Native Americans in California through 40 tribal clinics. CRIB is an Indian Self-Determination Act contract administrator and provides a number of statewide programs. Native Americans continue to experience some of the worst health inequities of any underserved population in the United States. The Department of Health and Human Services reports that Native Americans have significantly higher health disparities in depression, suicide, obesity, substance abuse, hepatitis, infant death rate, and diabetes than other populations. Recent Kaiser Foundation report reports similar findings, as well as higher health disparities in cardiovascular disease and experiencing frequent mental distress than other populations. Here are our requests. Number one, fully fund the IHS agency and ensure each IHS area receives an equitable amount of the resources. This honors the federal trust responsibility to tribal governments. As Chairman Andy Joseph noted just recently, the National Tribal Budget Formulation Work Group calculated funding need to be about $36.8 billion phased in over 12 years. The agency has not received adequate funding. For example, in 2015, IHS spending for medical care per user was only about $3,100, while the national average spending per user was about $8,500. This correlates directly with the unacceptable higher rates of premature deaths and chronic illnesses suffered throughout tribal communities. Second request, ensure IHS is not subject to sequestration that occurs as a result of the Budget Control Act of 2011. The law was designed so that federal programs that serve the most vulnerable populations were exempt from the full sequester, but this does not include Indian Health Service or a number of other programs serving Indian country. Third request, secure advanced appropriations for IHS. If IHS had received advanced appropes, it would not have been subject to the recent government shutdown, as fiscal year 2019 funding would already have been in place. Adopting advanced appropriations for Indian Health Service results in the ability of health administrators to continue treating patients without wondering if or when they have the necessary funding. Fourth request, please enact mandatory appropes for Indian Health Service. Funding for IHS should be treated as mandatory spending. This would be in alignment with the federal government's trust responsibility for health, which is the direct result of treaties, federal law, and Supreme Court cases. Fifth request, please increase appropriations to Indian country outside of IHS. Tribes and tribal organizations disproportionately receive a low number of Department of Health and Human Services grant awards. Therefore, Congress should grant awards directly to tribes, create set-asides for HHS block grants so that tribal communities have access to these funds on a recurring basis, and where states receive funds to pass through to tribes, Congress should require tribal consultation on the use of those funds. Sixth request, please enact long-term renewal for the Special Diabetes Program for Indians at $200 million. It is paramount to pass legislation to renew the program. The current authorization expires on September 30th, 2019. The program has not received an increase in funding since fiscal year 2004, which means the program has effectively lost about 25% in programmatic value over the last 15 years due to the lack of funding increases corresponding to inflation. My final comment is tied to my first recommendation, and that's to ensure current IHS funding is distributed equitably. CRIB has testified before about the lack of fundamental fairness in IHS allocation of program funding. The California IHS area is not receiving its fair share of purchased and referred care, hospital, health center, staff quarter, and joint venture construction, and other program funds. This persistent problem needs to be remedied, and CRIB and tribal health program representatives in California would like to work with the committee to address the issues. In conclusion, on behalf of CRIB, we thank the committee for holding this important hearing on tribal health and other programming, and look forward to the opportunity to provide further guidance. Thank you.
Thank you. I have to comment, your timing's impeccable. It's right there at the 5-minute level. Next, Ms. Tetnowski.
Good morning, Chairwoman McCollum, Ranking Member Joyce, and subcommittee members.
Microphone, please. Thank you.
Oh, thank you. Can I start again? Good morning, Chairwoman McCollum, Ranking Member Joyce, and subcommittee members. My name is Sonia Tetnowski. I'm the Chief Executive Officer for the Indian Health Center of Santa Clara Valley. As an urban Indian health program in San Jose, California, I'm an enrolled member of the Makah tribe, and I would like to thank the subcommittee for holding these hearings. IHC has been serving the American Indian community for over 40 years. We provide full service to 22,000 patients throughout Santa Clara Valley, and 73% of those fall within the poverty line threshold. I also serve as the president of the California Consortium of Urban Indian Health. SACUI is an alliance of 10 urban programs serving about 70,000 patients per year. We're committed to serving American Indian people no matter where they live. I'll be covering 4 key points during my testimony today. 1, it's critical that IHS receive advanced appropriations alongside other health services such as VA. We would like to request IHS be appropriated a year in advance. Although 70% of American Indians live off reservation lands, the urban programs only receive 1% of the IHS budget to serve this ever-growing population. We're asking for an increase from 1 to 2% of the IHS budget. 2, in recognition of the federal trust responsibility, American Indian health care belongs to the federal government, not to the states. It is my position that urban Indian health programs should receive 100% federal match for Medicaid services, a protection already enjoyed by IHS and tribal facilities. Urban programs are a critical part of the ITU health delivery system and should be included in the 100% FMAP protection. 3, the opioid epidemic is affecting American Indian people in both tribal and urban Indian communities. While we acknowledge the incredible efforts of SAMHSA tribal opioid response grants, urban programs were not eligible to apply. Please act to correct this oversight. 4, in 2010, IHS and VA signed a MOU to promote interagency collaboration. While this is great news, urban programs were not referenced. We maintain that this is a simple oversight. As a veteran myself, I know that our people serve in the military at higher rates than any other race and should have access to culturally competent health care by the ITU system. I ask you for the inclusion of the urban programs in this IHS VA MOU. I present each of you with this challenge coin to commemorate today and ask you to accept the challenge to address these 4 issues I have laid out today. Thank you for the opportunity to testify before you today and ask you again to help me to continue to provide culturally competent care to every American Indian and Alaska Native, no matter where they live.
Thank you for both your testimony and your service.
Thank you.
Next, Ms. Sanchez.
Good morning. I'm Teresa Sanchez. I'm the Board Vice President for Riverside San Bernardino County Indian Health, located in Southern California. And I'm also a member of the California Area Tribal Advisory Committee and a member of the Morongo Band of Mission Indians. Thank you for the opportunity to testify. IHS funding shortfall to tribal clinics. An issue was discussed with the acting IHS director both at the CRIB board meeting and through our conversations with the California area office that we received the same level of funding which we received in fiscal year 2016-17 for FY 2017-18. We had projected, based on historical calculations at the national level, we would receive a $1.5 million to $2 million increase based on the national IHS budget, receiving a 9.9% increase in 2017-18. We did not find out until the last day of the fiscal year what our final amount was paid, and it was less than the previous year. CRIB only received a 1.2% increase for all the clinics they represent. In addition, the acting director reallocated $25 million out of the inflation funding to address a lawsuit in the, acting director reallocated $25 million inflation funding to address I am so sorry, I lost my place. On the lease on the lawsuit on the lease agreements in Alaska, these funds should have come to the clinics for base funding. They acted on this change with minimal consultation with the tribes and only 12 working days notification after the July 4th holiday. To compound matters, they did not inform the tribes of this decision until mid-September. Finally, they had $33 million in unspent funding in the chef account, and they rolled this over for the agreement for the funding for the chef for 2018-19, but did not use this to cover the lease agreement lawsuit. All of these issues were raised with the acting director because of the lack of transparency at the national IHS level. The importance of providing purchase-referred care. Riverside San Bernardino County Indian Health and CRIB are working on a coordinated effort with other areas in the United States who have no access to hospitals to make this component a higher priority in the funding formula. Of the 12 Indian health services areas across the United States, 4 are formally designated to PRC dependent: California, Portland, Bemidji, and Nashville. The California and Portland areas rely on the PRC program to purchase all of their inpatient care, while Bemidji and Nashville areas are dependent on the program to buy most of these services. The tribal health clinics in PRC-dependent areas must use this extremely limited PRC funding to cover the cost of placing patients in non-IHS tribal hospital and are purchasing other specialty care services. The funding often runs out before the end of the fiscal year in the past, leading to the denial or rationing of inpatient and other specialty care. Although the remaining 8 IHS areas have inpatient facilities funded through IHS, these facilities also receive PRC funding. This further assists these areas in strengthening the system of care that they provide. A critically important need exists to move the PRC-dependent access to care factor from the program increases category in the PRC funding distribution formula to the annual adjustment category. This will increase the potential for PRC-dependent areas to receive funding for the purpose of eliminating inequities in funding for PRC programs, as specifically authorized in the Indian Health Care Improvement Act. As it historically and currently stands, the base funding category is first resourced, followed by the annual adjustment category, and if Any funding remains unallocated, it is moved into the last category of program increases with the access to care factor rests. And also with chef funding. Another topic at the PRC national meeting was the advocacy by PRC representatives for changing the threshold for the chef funding. This program pays for catastrophic medical costs after a clinic has met a $25,000 match and will reimburse clinics the above amount. The IHS acting director has not moved forward on the recommendation to move the threshold from $25,000 to $19,000, even though the issue has gone out for comments twice in the Federal Register. The acting IHS director was concerned that in order to implement the change, there is a statutory requirement to include a CPI adjustment factor, and the analysis by the PRC staff used 3.4% CPI rate. However, in reviewing the data through the last 5 years, the CPI would take 10 years to move from 19,000 to exceed existing threshold of 25,000. However, the National PRC Committee advocated for the change because a great deal could happen over the 10-year period, and the program had a $33 million carryover balance for 2017-18 fiscal year. I thank you for your time and consideration.
Thank you for your testimony. And last, Honorable Ms. Kitchayan? Kitchayan. I heard you tell Mr. Simpson, too, and then I blew it. I apologize. You have 5 minutes.
Okay. Good morning, Chairwoman McCollum and Ranking Member Joyce and members of the subcommittee. My name is Victoria Kitchian. I'm a member of the Winnebago Tribal Council, and I'm the chairwoman of the National Indian Health Board. I'm here today to talk about funding priorities for the Indian Health Service in fiscal year 2020. As we're all aware, and we heard from my colleagues today, the Indian Health Service is chronically underfunded for decades, and it's no wonder that the American Indian and Alaska Native citizens receive greater health disparities than any other citizens in our nation. And the statistics are staggering, with 5.5 years less life expectancy, higher infant mortality rate. We heard from some of these really sad statistics today, so I won't go on and on about that. But I just want to say that funding of IHS plays an important and critical role in those disparities. We cannot continue to financially starve the system and expect better health outcomes. We want to thank this committee for the bipartisan support we've received to increase funding IHS over the years. We truly appreciate the commitment of this committee to ensure that those increases happen. However, those increases have gone largely to inflation, population growth, and the rightful funding of contract support costs. So in order to truly achieve marked improvement and progress, we need to make a bolder plan for funding IHS. NHB supports the request of the Tribal Budget Formulation Work Group. Those tribal leaders are calling for fully funding IHS at $36 billion over 12 years. This funding would allow IHS to improve critical infrastructure as well as expand services to American Indians and Alaska Natives who aren't using the service due to underfunding. We begin this 12-year phase for fiscal 2020 with a $7 billion recommendation. That would include $2.5 billion for hospitals and clinics, which is the core services budget. In addition, $1.4 billion for purchase deferred care and $254 million for mental health. Also, we're calling for a separate line item for health IT infrastructure. We need to make necessary upgrades to our electronic health system. The VA is already receiving this investment, and we'd surely appreciate this on the IHS side. You can read more details about that in the written statement. Also, the tribal budget formulations testimony is on the NHB website. Today, I want to focus on a policy priority for NHB as well as the tribes, and that's securing advance appropriations for IHS. Thank you, Chairwoman McCollum and Ranking Member Joyce, for your leadership on this issue. The 35-day partial government shutdown in the start of 2019 had a devastating impact on tribal health systems. Tribes throughout the country reported ration care, reduced services, and some facilities closed altogether. This reckless shutdown destabilized Native health delivery as well as provider access.
tribal governments, families, children, and individuals. One tribe reported cutting services to ensure their health systems would remain open. We heard of cuts to transportation, behavioral health, prevention, TANF. Another tribe reported cuts to elders, culture, youth, and other community services. Others reported concern with outside health facilities not accepting the referrals from IHS. And one lost 4 nurses to the private sector during this time. So with all this, we must be doing something we must do something differently. Enacting advance appropriations of IHS would ensure that funding is available a year in advance and that we would not be negatively impacted by any unrelated political battles. Advance appropriations to help honor the trust responsibility that our ancestors entered into and ensure that the federal government would commit to upholding those treaties. And it isn't just the shutdowns. In September 2018, the GAO released a report noting that the current system for IHS appropriations and numerous short-term continuing resolutions places a serious financial and an administrative burden on the IHS as well as the tribes. GAO also noted that the current system of CRs and shutdowns make it hard for long-term planning, entering into contracts and vendor agreements. A significant impact on recruitment, especially in rural areas. And with a 25% vacancy rate, we can't afford to have any other wrenches in our system. And so the VA already receives advance appropriations, and other federally funded programs such as Medicare and Medicaid receive mandatory spending. And so we'd like to see, like VA, IHS receive some of that same commitment. It has a direct medical commitment to fulfill the legal promises made by the government, and we believe providing advance appropriations to IHS would create that parity between other federal health systems. I hope that we can work together today to work towards this. NHB stands committed to this goal, and we'd like to help you champion this on behalf of the tribes. Thank you today, and I'd be happy to answer any questions.
Thank you all for your testimony. Madam Chair, do you have any questions?
I do, but I'm waiting to get an answer back from my staff if they're not in a meeting as to how much we've spent between the DOD and the VA trying to get their medical records straight. So,
Too much.
I'm gonna wait. Too much, but million.
Yeah, that was one of the biggest surprises I had when it was on MilCon, was how much we spend on VA and we still not get it right between the service and the VA.
Should I put you on the spot and ask you the number?
It was
Too much.
a term ago, yes, that I was on it.
I think we could spend a fraction of the cost getting BIA medical records up, but I'm gonna wait until after you, Mr. Simpson, are done. Thank you.
Mr. Simpson?
Thank you all for being here and for your testimony. Instead of trying to find a way to keep things funded during a government shutdown, what we ought to commit to is that we're not going to shut down the damn government anymore. Bad policy, bad politics, just stupid. I don't think you'd find any argument from anybody on this committee or anybody on the Appropriations Committee that that's no way to run a railroad. But I understand your issue and your problems, and it seems like we always forget about, when we're over the years when we've done certain things for certain agencies to prevent things, we always forget to include Native Americans in it and stuff. So that is a problem. Just out of curiosity, Sonia said that you had 22,000 patients throughout Santa Clara County, right? And you had 70,000 patients that come from surrounding community and so forth.
Yes.
Are those all Native Americans?
Yes.
Do you serve anybody outside the Native American population?
Yes. I'm also a federally qualified health center, so I serve everybody.
Okay. And the reason I ask that is right now they're having an issue in the Idaho legislature between they're trying to expand dental care to allow dental therapists on Native American reservations, which the Dental Association is okay with. The problem is that if they then serve also non-Native populations, that creates a problem of expanding the scope of practice. And that's the challenge they're kind of dealing with right now. There are only 2 states that allow dental therapy, one of them Minnesota and one of them Alaska. And I've always taken the position I don't want the federal government determining what scope of practice is. That's the state's responsibility.
Yeah.
And so they're trying to work that out, and I have no problem with allowing dental therapists on reservations to serve Native populations, particularly in areas where you can't get a dentist to go. you
Right.
know?
There's so many rural communities, and
Yeah.
access is critical. And recruitment has always been an issue, whether it's tribal or urban. So we continue to face that across the board with all providers. Yeah.
And but that's the challenge, is
Yeah.
serving the Native American population versus the non-Native American population by the same therapist, you know.
Right.
So they'll work it out, but it's good that they're discussing it. But thank you all for being here today and for your testimony.
Thank you.
Do you have a question? I have one.
I have one for Mr. LeBeau. Under former Chairman Calvert's leadership, the subcommittee provided significant funds to the Indian Healthcare Improvement Fund to try and reduce the funding disparities across Indian country. Did those funds considerably improve the situation for California tribes?
Well, not in the way that we had hoped, given that there's over 100 federally recognized tribes in California and, well over 50 tribal satellite clinics in rural and frontier regions of California. The end result of the first distribution of funding to the California IHS area resulted at about 3 to 4 small tribal clinics receiving some funding. For those particular clinics, that's great news, in terms of, continuing to deliver care. But for the vast majority of tribal clinics in California, they saw zero funding during the first go-round. I happen to serve on the IHS Indian Health Care Improvement Fund work group representing California, along with a gentleman by the name of Chris Devers from Southern California. We continue to advocate and make recommendations to the full work group and to IHS to strive to ensure that more resources are provided to chronically underfunded IHS areas. That's, the issue continues to persist, however. So we do appreciate the support of the committee in providing funding for that line item. It was helpful. Additional support and direction and guidance, I think, from committee would be even further helpful. Thank you.
Thank you, Madam Chair.
Thank you, Mr. Joyce. Current contract for VA going out 10 years is an additional $16 billion. My staff has said, he told me he was going to try to pull together how much the government spent in the last 20 years. I told him this was good enough to make our point. Thank you. I think we need to get better. We heard last year about challenges with medical records in general. Some systems, I think in California, we're still using DOS. If I heard, it was not very efficient, not very practical, and not right. I would like for a second the special diabetes program. The doctor mentioned, and almost every tribe when it comes to health care talks about it, has been flat funded since 2004, and the amount of dollars that it saves by preventing cost overruns in Medicare, Medicaid, any of the federal programs that tribal members might be eligible for, plus the Indian Health Services. Is there a repository someplace so that we know how many people are not being served by this program because we've not increased funding? Do you know if that's available either through the National Congress of American Indians or any of the health boards? Because I think that would be helpful in us in making the debate that we should look at increasing those funds, because it's going to save lives. It's going to improve the quality of life, but sometimes the argument that we need to have is it's going to save tax dollars with our fellow colleagues. Do you know if that's available? And if so, would you maybe see if you could get it to us?
Sure. So the section of the testimony that I provided was a result of the work of the National Indian Health Board, where they're calling for $200 million to fund the special diabetes program for Indians. NIHB does note that treatment of end-stage renal disease costs. It's about $90,000 per patient per year. So there's a reduction in the cases of end-stage renal disease that translates into significant cost savings for Medicare, IHS, and third-party payers. In addition, The program has proven itself effective, especially in declining incidence of diabetes-related kidney disease in particular. The incidence, again, of end-stage renal disease due to diabetes in Native Americans has fallen by 54%, a greater decline than for any other racial or ethnic group. And so that detail is derived from the National Health Board, and I know we have representatives from NIHB here today. We'd be glad to provide you a full report on that particular issue if you would like.
Thank you to my colleague for acknowledging NIHB's work in this space. And we always talk about SDPI being the most successful public health and prevention program. Special diabetes for, right, and acknowledging that its success is based on the for the tribes, by the tribes, and each tribe being able to design their unique program around their community's needs. And I think you raised an important point on the data that we need to continue to collect, and NIHB stands positioned, and it sounds like an amazing pilot project that we'd love to participate in, so that we can ask our funders and our appropriators to continue to fund and increase this program to save dollars in the end. And we always say that IHS would rather cut off a limb than prevent it, and that's just devastating and sad. And why is that the level of care that we're providing to our First Nations people?
Thank you, Mr. Joyce. I think that we're looking at how we're reducing the cost of the disease as it progresses, but the one thing we probably won't be able to quantify is when someone starts changing the way they're preparing food at home, everyone is impacted by it. So we actually might see a decrease in diabetes in the future. So I think making sure that you have the tools to collect the information would be helpful. And with that, I yield back, and maybe Mr. Simpson would like to introduce the next panel.
That's okay, go ahead.
No, he didn't want to do it.
You didn't want to do it.
But I certainly appreciate it. As my sister's a juvenile diabetic, and having watched it all my life, I can appreciate the work that goes into it. So I'm with you on whatever we can do. And thank you all for your testimony and being here today.
Thank you. And these are for members of the committee.
Thank you so much. So I noticed Victoria's listed here twice.
Sorry, it's too far to reach for me.
Selected that they're going to speak on, she's going to speak about the Winnebago
Okay,
hospital.
that's fine.
Thank you all for your time. I appreciate it.
Victoria, you can just stay up here. Okay. Hey, good to see you.
The other thing we tried to do last year was the loan making scholarship money to grow
The workforce, yeah. I highlighted that quite a bit, and they've got some, that intern program that we were talking about.
This is kind of shaped like an arrowhead, you know?
If you want to move in a little closer, if it's easier for you.
It's hard to surprise Joyce here.
You slip over one more than you had the mic to yourself.
Yeah. You got a twin sister, don't you? That was just here.
How'd you work in another 5 minutes? I know. Just kidding.
So I welcome with great honor the chairman of the Fond du Lac Band of the Superior Chippewa, the council member from Bad River, Great Lakes Superior Chippewa, and once again a tribal council member from Winnebago Tribe of Nebraska. And if we could ask the chairman of Fond du Lac to lead off the panel. Thank you, sir, for being here. Good to see you again.
Bonjour, Naganimus and Disnakas Nagachiwan on the Nujaba. Because you do them. First of all, I'd like to say thank you and good morning, Chairman McCollum and members of the subcommittee. Thank you for the opportunity to testify today. My name is Kevin Dupuy Sr. I'm the chairman of the Fond du Lac Band of Lake Superior, Chippewa. I have submitted written testimony for the record and discussed in many areas where increase in federal funding is needed. Today, however, I'd like to focus on importance of federal funding for Indian Health Service and Indian health care programs. One thing I'd like to start off with is I'm not going to sit here and tell anybody anything any different that everybody has already said, the disparities that we have in Indian country, throughout Indian country. But what I would like to do, since my written testimony is in there, I want to kind of go off it a little bit, And I want to talk about the reality of what's happened within Indian country, not by what's on a piece of paper, but by testimony from me. I'd like to start off with the opiate problem. It's an epidemic. Last time I testified, I brought up a scenario, and I'd like to do it again for the ones who weren't here before. I watched a video one time, and the video showed a group of Native kids in a home. And what they did, they were having an opium party. Never heard of it before. A heroin party, excuse me. Never heard of it before. So they brought in ice, and they filled up the bathtub. But they also brought in Narcan. And what they were doing is taking heroin. And when somebody would go out, they'd give them Narcan. And to shock them out of it, they'd put them in the ice in the shower. That's what's happening in Indian country. That's what's happening in our communities. Our people are dying. Our people are dying in a rate that it's unfathomable. We grow up and we're taught things to never forget who we are and where we come from, and to respect our elders and the ones and our ancestors that came before us, and to put in place a job that we're supposed to do today to ensure that there's a future for our unborn. It's hard to do that sometimes with the issues that are happening. We do have problems on our own reservation. We do have a water issue that's on our own reservation, where we have bad water in one of our communities, and looking for funding to support that instead of digging into our coffers to do that with the lack of funding that everybody knows that exists in Indian country. We had people, Native people in front of you earlier that talked about the issues in urban areas. Well, we have a thing in Minnesota called Tent City that was in Minneapolis. And I observed it, went there many, many times to watch homeless people, drug epidemic, drug addiction, sexual issues, prostitution, everything that you could think of. And it's in a healthcare, it is based in a healthcare issue. So we met in St. Paul, and we had a meeting of all the tribes to address the opiate crisis and the problem. We had all our funding mechanisms were in the same room. So I asked everybody that day, does everybody here work on tabletop exercises? And they said, yeah. I said, well, there's one 11 miles away. So if you want to have a true tabletop exercise, put everything down today, go into Minneapolis, take a look at it, see the medical crisis that exists in a street next to the highway. Mm-hmm. And everybody just put their head down. So these are people that we're asking funding from, that were in the room. And it makes my heart sick and hurt to know that the same people that were coming in front and asking for funding that were on the table. And when we asked them to come over there, I asked them to come over there to take a very good look at it and see exactly what's happening. If you can address that issue, if you can work on that issue right there, then we can run across the country and Indian country and work on every one of them that were there. But to no avail, they just put their heads down. So I go home every day and I have to report back to constituents and tell them how it went in DC. I don't know how it's going to go in DC. All I can do is speak from my heart and the written testimony that's there. But we go home to these things, and we go home to them every day. I can't speak for any other group of people, but I can only speak for the indigenous people of this land. The funding has never been adequate, and everybody knows that. It will never be adequate. But one thing that we can sit there and be proud of is knowing that we know how to stretch the dollar. If one group of people on this planet knows how to stretch the dollar, it's us. But we're stretching to a point where we can't stretch it anymore. I want to bring these things forward, and so it's a face-to-face thing that you can see that it hurts. It hurts all of us. Our people are dying. People are dying in a manner that we can't control. And every time one of our children die or a person dies, and when we look at the 7-generation principle, that's 7 generations that are never going to make it. That's sad. It's really, really sad. But I do know that you guys listen, and I understand, and I talk with Ms. McCollum, that her drive in the state of Minnesota and what she tries to do is, it's hard to explain, except it's impeccable. And so I appreciate that, and I appreciate everybody on this committee. But I do want to bring this to this committee to ask for the simple principle of help. Not through a piece of paper, because we do that all the time, but to hear us and listen to us what we're saying. And some are going to sit here and some are going to repeat what somebody else has said. But you need to hear the stories of what are happening. You need to hear the truth. If you can see these videos and if you can hear the truth and see the truth, and this data that exists and questions that were asked earlier, I need to bring it up, is that the tribes have the ability to do something that hasn't been done before, and that's taking in and helping the urban communities in this way, is to open up clinics inside the urban area. We have done it. We've opened up a pharmacy 200 miles away from our reservation, where we serve all Native people. And we can collectively do that and come to an agreement that this is what we need to do for our people. We'll be able to strive. So with that, and I know I'm out of time, so again, thank you very much. Miigwech.
Ani Nindinwe Magani Dog Niji Gakina Nitsa Bija Kint Indigenous Cause Wabashashi and Doda Mushgazibing and Dunjaba Nimigwitchwe Ananika Gil Kinago Gino Agape Jayago Mas Onongum New Jaganashi Majinate. So good afternoon, respective Committee on Appropriations. I really appreciate the opportunity to sit here before you. My name is Dylan Jennings. I serve as a council member for my community, the Bad River Band of Lake Superior Tribe of Ojibwe Indians in northern Wisconsin. I come to you from one of the most beautiful communities in the world. I'm here to talk with you about something that's dear to us, and in our language we say Bimat Diziwan, our life way, the way that we live our life and the health that we know as our people. And I believe most of the things I'm gonna talk about or summarize can be summarized with a single example. And I want to talk to you about a community member, specifically a woman in our community. And this is, very, very tough to talk about, but a woman who struggles with behavioral health has just given birth to a baby who was diagnosed with neonatal abstinence syndrome. As a result of the diagnosis, the baby was removed from the mother's care. In an effort to work towards reunification with her baby, the mother attends treatment. Upon the mother's release from the treatment center, she returns home. The mother receives little to no back-end care and relapses, which often happens in our communities, exposing her to the risks of hepatitis C, HIV, in all of the course of her relapse. Unfortunately, this is not just an example, but this is a reality, as my relative here talks about. This is a reality for my community. Between 2010 and 2015, the number of drug-addicted born babies from the primary hospital that serves our tribal citizens in the local county was roughly 27 babies out of every 1,000 births, the highest in the state. At present, of over the 50 open child welfare cases currently under the tribe's jurisdiction, about 86% of those is due directly to illicit drug use risk. We're talking about our babies here. What can we do to keep this from happening? These are not just members, they are our children, they are our future. They're our future leaders that will hopefully be sitting here someday in our place. We know the best way to help ourselves, but often lack data to capture, assess, and evaluate the status of the tribe. The Indian health system should provide direct funding for comprehensive behavioral health data evaluation. That's something that we really could use. Direct funding to the Indian health system should not be restricted to one identified drug type. For instance, grants typically, when they come out and they're announced, they identify certain types of drugs that they're going to address, and sometimes that far limits our abilities to utilize them the way that we need to utilize them. And so, the tribe, we are asking that, as we move forward, we would really appreciate the ability to utilize different grant funding for multiple issues that we encounter. To construct, to provide rural tribal communities the same opportunity in local municipalities that local municipalities and states have to provide infrastructure for our efforts. The opioid epidemic has hit Indian country hard. You're going to hear that for years to come, right? And many people have already said this. According to surveys conducted by the CDC, American Indians in urban areas are dying of opioid overdoses at the highest rates, closely followed by Caucasians, American Indians and American Indians in rural areas. Some communities, like Bad River, have been able to address opioid overdoses by a targeted campaign to equip community members with overdose reversal training skills and the provision of naloxone, the overdose reversal medication. However, nationally and in Bad River, tribal and rural first responders and programs as such lack funding and support needed to address the epidemic. In Bad River, there have been several opioid overdose events where the first responders arrived at the scene, determined that the individual is overdosing and have not had naloxone to administer. The lack of access to some of these resources in these entities puts entire regions at greater risk of death. Targeted funding to support tribal fire departments and first responders in procurement of naloxone, including nasally administered naloxone, which costs approximately $75 per kit, would save many of our community members. Within our communities, the opioid epidemic translates into many forms of disease, which you all are very well aware, including skyrocketing rates of hepatitis, increased risk of HIV transmission, behavioral and mental health illness, and social isolation. The Bad River Band applauds the administration's goal of ending HIV transmission within the decade. We believe that addressing HIV transmission will go hand in hand in Bad River's goal of ending the epidemic of opioid addiction within our communities. According to a 2016 HIV surveillance report, Native American women who inject drugs contracted HIV at more than 10 times the rate of African American, Asian, and Latino counterparts. Ending HIV transmission will require funding and resources at all risk populations, and especially for Native American communities experiencing high rates of injection drug use. The current funding plan, which targets 7 states and 48 jurisdictions, does not include many of our rural areas in the Great Lakes region, including Upper Michigan, Wisconsin, Minnesota, and North Dakota. Targeted funds to prevent HIV transmission are needed, absolutely. Micro and macro funding streams are essential to incentivize treatment for people at high risk for HIV, including people who inject drugs. The Bad River Band also applauds the administration's goal of providing pre-exposure prophylaxis or PrEP, the daily medication that can be taken to prevent HIV infection, to all at-risk people. Demonstration.
Councilmember Jennings, I have to ask you to suspend for a minute, and
Okay.
we'll have more questions, but your testimony is very compelling. Thank you.
Well, thank you. I appreciate you guys for taking the time to listen to us. So, miigwech miu.
Ms. Ketchitan.
Good morning again, and my name is Victoria Kitchian, a member of the Winnebago Tribal Council and chair of the National Indian Health Board. Thank you for having me here today. As you may recall from my past testimony, the Winnebago Hospital still holds the distinction of being the only federal hospital to ever lose its CMS certification. This occurred as a result of years of mismanagement and serious patient care deficiency, including lack of staff training, lack of necessary equipment, and overall hospital operations. I know these issues have been reported to you as far back as 2010 and were again brought to the forefront in 2015. These ongoing issues have resulted in painful loss of life and much unnecessary suffering by our people in Nebraska. When this ordeal began for the Winnebago tribe in 2015, we were adamant that the Indian Health Service created this situation, that they created the problem, and that they needed to fix it. Well, as days turned into months, months turned into years, the Winnebago tribe took a stance that we could wait no longer, and that we needed to solve our own problems. We initiated an intensive planning process and entered into a self-governance compact agreement with the Indian Health Service, and as July 1, the Winnebago tribe assumed full management of that IHS facility. And now it's known as the 12 Clans Unity Hospital. We're very proud of that. Since July 2018, the tribe has worked diligently to assess, stabilize, and really improve the hospital operations. Priority has included establishment of the organizational structure, board training, recruitment, and overall improvement, and of course, working towards CMS certification. The issues at the hospital did not happen overnight, so we understand that it's going to take considerable time and effort to change the organizational culture and all the necessary improvements that we need to achieve CMS certification and to become the top quality healthcare provider that we know that we can be for our tribal members. It has been a period of significant change, not only for the organization, but for the community, and it definitely has not been without challenge. But the Winnebago tribe and our team at 12 Clans Unity Hospital are confident that we can be successful, and we are already seeing those remarkable improvements at the facility. During this time of transition, your support that has been critical, the added oversight from this committee, our congressional delegation, our congressional staff, And all that would not have been possible. The tribal assumption really counted on that support to continue sustaining operations, and we appreciate that. And we look for your continued support as we make progress. Today, for example, our ongoing needs include continued recruitment. The facility has lost CMS certification. The facility has documented inadequacies. You know, it's just not has the best reputation right now. And we hope to build up that solid reputation and make it a place that people are proud to work, where people are proud to come and receive their care. And we're confident that the tribe will be positioned to turn that place around with the necessary resources. We know that permanent full-time employees that are vested in the community as well as our facility are what we need, but that's going to take time. We heard about the 25% vacancy rate earlier, and that's something that's just our circumstance. We'll continue to work on these ongoing recruitment efforts, but in the meantime, it's a tremendous amount of money going to locum tenens contracts, nurses, providers, and addition radiology laboratory. So there's considerably more costs paying contractors than permanent staff, but we're working on it. We've also identified a need for ongoing training and technical consultation with regard to meeting hospital rules and regulations for all departments. Although the facility has been in existence for some time, it's essentially a new hospital. And the tribe has assumed management, but it includes revisions to the policies and procedures, operational plans, processes to really transition to a non-federally operated facility. In addition, meeting all the CMS requirements of participation. So, and on calling on the best practices in the healthcare industry, you know, we want it to be the best facility for the patients, not just another poorly ran federal hospital. Another challenge was presented during the recent shutdown. We would have had great difficulty continuing our services had we not received a special appropriation from the Special Accreditation Emergencies funded in 2018. And it's that lack of third-party revenue from the LEAS CMS certification that left us without resource. And without this committee's help, we would not have had that gap funding. And so we're also really thankful in calling on that same level of funding in 2018 as we continue to make the necessary improvements. And the replacement of those funds and the CMS certification were most apparent during this shutdown. We hope to provide financial stability for the organization and while we work to restore the certification. The Winnebago tribe also supports what we've heard today so much about the advance appropriations of IHS, and I'll also add BIA, because we know that many of the services that those agencies provide for our tribal communities are intertwined, and they're not in the silos that sometimes we see within the agencies, but they're integrated services within our communities that collectively make up the livelihoods of our tribal members. So we want to just also give support for that initiative and really impress that funding directly ties to the patient care and the community wellness of our tribal nations. So thank you today for this, and thank you for allowing me to speak with you once again on behalf of the tribes. And the Winnebago tribe surely appreciates the continued support and the support that we can to restore this certification and be the success story of the trauma that's happened in the Great Plains and as well as amongst the Winnebagos. Thank you.
Thank you. Mr. Simpson?
Again, thank you all for being here. And Kevin, thank you for your story. That's why we have these hearings, is we need to hear these stories and directly from you, not just here in Washington, but out in the hinterlands around America also. And we've tried to, as a committee, get out to as many tribes and visit them in their homelands as we can. And I think that's an important aspect, and I know that the chairwoman will continue to work on that. Dylan, you mentioned one thing that caught my ear, well, more than one thing, but you said you'd like to be able to use grants and stuff on a broader basis than what they're, we've talked about this in the past, and I'd like you to be able to use these grants wherever you think is appropriate. I mean, this is your country, it's your money, and you ought to be able to use them where you think it would be most efficiently used. But you do know that completely screws up our bookkeeping at BIA and IHS and all of that. I mean, that's the kind of reaction we got from them. How can we keep track of anything if we allow them to do that, Yeah, maybe we ought to treat you kind of like adults that can do what's best for your nations. Anyway, thank you for being here today, and thanks for your testimony.
Mr. Joyce?
Thank you all for being here, some of you twice, but appreciate the story as well. And I can tell you that the opioid epidemic that's ravaged our country is not, there's no part in this country that's immune to it. And unfortunately, I've heard those type of stories before, not necessarily in native lands, but everywhere. And as somebody who's put up a bill to try to make Narcan available, I end up having a lot of people say, well, these people, you hear a story of it being abused like that, then why are we even doing it? And these are still lives. They're entrapped unfortunately, in the free-for-all with these drugs. And we need to treat the addict first, and then we'll deal with the rest of it. So thanks for all of you for being here today in your testimony.
Councilmember Jennings, you had wonderful things that you shared, more than what I had in my book. So I want to make sure that we have a copy of your full testimony that you were entering for the record, and so that the whole completion's in there. So if you would share us with us at the end, it would be greatly appreciated, sir.
Absolutely.
I wanted to ask you a little more about, in the testimony that I've been looking through, about the 34OB drug pricing program, on how you think it should be protected and expanded. Would that have helped you with perhaps your first responders having what they needed at a better price than $75? Or is that for other drugs? If you'd just help point us in the right direction as we research this.
Yeah, I think it could also make drugs like naloxone a little bit more attainable for our community, because right now we're really restricted in how we can use some of the grants we're speaking about or some of the funding that we receive for some of these things, and so some of them won't allow us to spend it on some of these life-saving treatment drugs. So, we're kind of caught with our hands tied where a lot of our community, kind of grassroots efforts are focused on just trying to get these drugs into the hands of our first responders and fire teams. So I think, yeah, that could be something that would help in that realm too.
When you were talking about the shutdown and the effect on the Winnebago Hospital, it really was a lifesaver that you had that appropriation put in place to deal with the emergency. But some of the things that, in reading other testimony that came up, and I'm wondering if it's true for you too, you have doctors and nurses and medical direct delivery practitioners that you're trying to recruit. And one of some of the testimony that I was reading through the other day was the fact that the way even placements for ads are put forward, that community members don't know, like if because there can be ladder to successes for jobs. And we did this in the Twin Cities at one of our hospitals at Regents, that people who came in and were interested in working in a hospital, interested in working in healthcare, sometimes started out doing prep work and cleaning and other things like that. And then they said, I want to learn how to draw blood. So it kind of went up the workforce ladder. Are we reaching out to community members presenting those opportunities for ladders of success, ladders of opportunity to go up in the healthcare field? Because what we're paying when you have to go out and with your precious dollars, bringing a contract is costing a lot. And it's also a way to build pride and confidence in the hospital for community members. Could you maybe address what's going on with workforce and what we might be able to do better?
Yes, we certainly always are looking for ways to develop our own tribal members and community members, and we call on partnerships such as with our tribal colleges and building programs with not only our tribal colleges but some of our area facilities for residency opportunities and things. So we're having all those discussions, and everything's on the table at this point because we want to create pipelines of medical professionals and administrators that are going to be committed to our community and aren't going to be transferred or detailed here or there. And so that's the difference, that we have the latitude to make those type of adjustments and partnerships for our compacted facility.
If there's more we can do working with the tribal colleges and that, please let us know, because this is a serious issue, making sure that we develop a pipeline, right?
Well, we could.
A good pipeline.
We could provide greater funding to the IHS scholarship program. There's many Native applicants that apply for that program and are overlooked, and there's just not enough funding to go around. But we know where we can improve. The National Indian Health Board has a relationship with the American Indian Physicians Association, and it's these conversations that are, we're calling on the practitioners to say, what can we create to help our young people even pursue these pathways. We could do a better job on STEM education. I mean, where do we begin? We really need to start sooner with building these professionals and credentialing them to have the confidence to practice in our communities.
Good. Chairman, you mentioned drinking water in your full testimony, and sanitation. And could you maybe elaborate, add a little more to that for the committee, because that's often overlooked when we're talking about health and wellness, but it's so important, and you had it in your testimony.
Yes. Yes, we have a community on Fond du Lac that we call the Monoman community. And the water that we had came from groundwater as well. Well, the system went bad, and the system couldn't control it. Well, we ended up getting toxins in the water. We looked through IHS to get funding to see if we can put an above ground water tank at Forest Main. We can't get the funding to do that. So what we ended up doing was putting money inside of our coffers right now. And I hate to say it, but it's reality, is we had to give the I think it's called Brinkman filters to each one of the homes. And that's what they're running out, but we're not treating the water. We don't have the money or the help to treat the water itself. So we dug several test wells, and we have different wells that are coming with a better water. But the distance that we need to do that goes back into the infrastructure side of it. We have to travel through ground for miles to reach that.
Thank you. I'm going to look some more into that, and thank you for elaborating on that. And it just goes to show, even states like Minnesota, which are water rich, water is a sacred resource, one that has to be treated with great respect. And even when you're surrounded by a lot of water, to know that you don't have potable drinking water for your family, it feels like a real tragedy to me, and I'm sure it does to your community. I want to thank you for the extended testimony, Council Member, and thank you all for being here today. Miigwech.
Miigwech, thank you.
David, you're up. You're up to bat. I'm going to see if I'll go see. David's, I'm going to have David introduce the next panel. So.
Good morning. Thank you all for being here. And if you hadn't been here in the beginning when we discussed the ground rules, each of you will be given 5 minutes for your testimony. And then we'll have questions, I'm sure, when we're all through. And we'll go in order as they were laid out here on our list. And we'll start with Mr. Miguel.
Chairwoman McCollum, Ranking Member Joyce, and members of the subcommittee. My name is Robert McGill, and I'm honored to serve as the chairman of the Auction Indian community and give you testimony to you today on our community's priorities. First of all, I'd like to thank the members of this subcommittee for inviting me to testify today. Despite the administration consistently proposing cuts every year to the many programs that tribes utilize, this subcommittee increased funding for the Bureau of Indian Affairs, the Bureau of Indian Education, and the Indian Health Services by over $303 million from 2018 to 2019, so thank you. Thank you for the continued dedication to the trust responsibilities of the federal government to the tribes and for the increase in this much needed funding. I'm here, and this is my 4th appearance before the subcommittee in recent years. And today I'm here to testify on a number of important issues to my tribe, including funding for healthcare programs, tribal self-governance, and other important grant programs. Auction has always been a farming tribe, and our name is directly derived from the O'odham word that refers to a type of farming traditionally practiced by the Auction people. Throughout our history, we have been farmers and continue to be farmers today. We own and operate the Auction farms. We cultivate more than 15,000 acres of farmland, and the farm has been a central economic enterprise for the community since the 1960s. We also have economic entities focused on gaming and hospitality that have grown into major sources of economic development for the entire area. We are direct neighbors with the city of Maricopa and lie about 35 miles south of Phoenix, Arizona. We are a small but growing tribe with 1,114 enrolled members, and as the area surrounding us continues to grow at one of the fastest rates in the nation, we are committed to being good neighbors while also working hard to build a stronger future for the next generation of Auction community members. Advanced appropriations are a necessity for tribes going forward to ensure that funds are available in advance to alleviate the unfortunate circumstances so many face during the partial government shutdown. Currently, critical federal programs of the Department of Education, Department of Housing and Urban Development, Department of Labor, and Veterans Affairs are also authorized for advanced appropriations. Funding uncertainty causes tribes to redistribute funds from other tribal programs just to get by. Advanced appropriations will prevent future lapses in funding associated with government shutdowns and will help in keeping critical services uninterrupted. One of our tribe's top priorities and challenges is to provide our members with high-quality health care and health services. Auction is a fairly young community. 40% of our membership is under the age of 18, while almost 13% are over the age of 51. This is important for predicting health disparities and prevention going forward. In 2017, the community conducted a community health assessment to determine areas of emphasis and need for prevention and outreach. We have developed a community-based action plan to help determine areas of need and identify areas of strength concerning health and wellness for our people. As I testified last year, the Indian Health Services grants program are critically important to our community. The Special Diabetes Program for Indians grant is utilized by our communities to emphasize physical activity and youth programs for our members. The SDPI program was reauthorized by Congress in 2018, and the SDPI was renewed for 2 years. We thank the subcommittee members who supported this reauthorization and your support to continue funding for this very important program. We asked the subcommittee to increase funding for the SDPI program to $200 million for FY 2020. The Auction Indian community is a compacted self-governance tribe with the Bureau of Indian Affairs. The compact enables the United States to maintain and improve its unique and continuing trust relationships and responsibilities to the community through self-governance for various programs, services, functions, and activities, PSFAs, such as our public safety, social services, courts, road maintenance, and various other vital programs. The community is also a compacted self-government tribes with the Indian Health Service for our EMS ambulance program. The community applied and received 2 tribal self-governance Indian Health Service cooperative agreements, grants under planning and negotiation. We truly appreciate as the funding have assisted the community with furthering the future of the Auction healthcare. Rural Native American communities have inadequate access to broadband service, creating a disparity that grows daily as our society becomes increasingly dependent on internet-based communications. By expanding access would assist with retaining accessibility to up-to-date technology in regards to healthcare, public safety, and education. I understand there is funding for this in the Department of Agriculture. However, we recommend the subcommittee consider making rural broadband expansion funding available for tribes through the Bureau of Indian Affairs or Bureau of Indian Education, as this is a public safety, educational, healthcare issue. In conclusion, I would like to thank the chairwoman and ranking members for holding this hearing and engaging in the government-to-government consultation to hear our community's priority. We hope this subcommittee will continue to work good with the communities and address the challenges tribes face as an administration that has in the past recommended zeroing out multiple programs that tribes rely on to ensure the well-being of their members. Again, thank you for the opportunity to testify today and to share with you our community's priorities. I hope my testimony today has given you meaningful insights into how these federal programs are positively impacting our community members. Thank you.
Thank you, Chairman. Chairman Flying Hawk, you're next.
Thank you, members of the subcommittee okay. Thank you, Madam Chairman and members of the subcommittee. My name is Robert Flying Hawk. I'm chairman of the Yankton tribe. In our language, it says Ihankwa, so that translates into the village. We are here, and I'm here representing our members and asking that the dollar amount, the budget not be cut, to remain the same, if anything, but asking for an increase to help us at home and throughout our neighboring communities. We have a hospital that has been stopped. It's no longer open. It is open from 7 to 11 at night, and then the working hours. What that causes is for our members to not receive the care that they're needing, that we are needing. We just recently lost one of our members, a 30-year-old lady, because of drugs overdose, froze, and our ambulance service can't take our members to our own hospital. They go to our community hospital, which is within our area. But then that creates a bill for each of us as members. So as a member, if I'm having a heart attack, and those hours aren't open at the hospital that I attend, the IHS, I'm going to sit there and try to calm myself down and not have the heart attack until our hospital opens up so I can go in and get the services that should be available. But because of that dollar and because of our hospital being shut down and there's no emergency care there, we refer out our patients, our members who go for the things that are needed, the services that are needed. This is real. It's real life and a matter of life and death for us as members. We need our hospital back. We need our emergency care back. That emergency care will allow that ambulance to come to our hospital so that our members can feel comfortable that if there's a pain in their chest, then the ambulance will be called and they'll know that they can get to our hospital without fear of being strapped with a bill, with a medical bill that we can't afford as an individual member. Our children, especially now, are looking at what has got a cough, pertussis, a whooping cough, I think, that hasn't been around for a while. But our children are showing signs of that, and why is that? So we're here. I'm here trying to ask why. The question why is that dollar unavailable? It's there. We need the qualified staff. We need those services delivered to us as members of our nation, of all of our nations on the Great Plains. And we suffer, I think I heard in the testimony earlier from Winnebago, those things that happened at each of those facilities and were shut down. Now, as a government and a treaty that was signed, the government has a responsibility to us as a people, and we would like that to be known, to be recognized, and to at least follow up on that, and to ask, to hear us, give us that help that we're asking for. As I said, it's a matter of life and death for us, and I have grandchildren, and I don't want them to suffer something that would possibly take their life. That is is not in my hope, my dream. It's a prayer that I have every morning that our people will be well taken care of. Our health is number one for us, and so I'm here to ask that you consider that, and I wanted to thank you for hearing us and giving us this opportunity this morning. Thank you.
Thank you, Chairman. And last but not least, Chairman Frazier.
Thank you. I want to thank you, committee, for allowing me the time and the honor of speaking before you guys. You know, one of the things, I got elected back in tribal politics. I first got elected in 1998. And at that time, healthcare was really an issue on our reservation and on the Cheyenne River Sioux Indian Reservation. And back then, there was a lack of resources, particularly financial. And I ended up being elected chairman in 2006, and then I was out for 8 years, and I come back in 2014. And healthcare has not improved on the Cheyenne River Indian Reservation. But one of the things I learned is it wasn't lack of resources. We were fortunate to get a new facility, which allowed us to get a big, pretty good increase in our funding. And one of the things I want to talk about, I know it's been talked about quite frequently in Congress, is a wall. One of the things we're fortunate in our service unit that we have a huge, to us it's very huge, but it's a pretty good savings in third-party billing. It's in excess of $24 million. And one of the number one priorities of our service unit is to build a wall around the entire facility. I mean, we find that really just crazy with all of our needs. One of the things that we have, and we have a need of, is dialysis. I mean, we've done a feasibility in conjunction, and I'll kind of get to where the problem lies, but it's around $5 million. I mean, and if with $24 million, we definitely have the resources to build it. Right now, we have members. We do have a private dialysis on a reservation, but because of the amount of people that need it, we still got 3 to 4 members that travel either to Spearfish, South Dakota, or Bismarck, North Dakota, 3 days a week for dialysis, and they're about 135 to 150 miles one way. And my mother was on dialysis, so I know the toll it takes on a person with dialysis. So it's really a issue. We got high suicide rates. I know last year which were not very sad, but we averaged about 11 attempts a month, and we were nearly 1 completion a month, which is really sad. I mean, we got a lot of high needs, treatment, meth treatment. I mean, these are things we try to work with. We put resolutions, requests in IHS to build these facilities. I mean, they have the money on a reservation, but one of the biggest problems where it lies is in the area office. I mean, I will downright call them dictators. They micromanage the service units. Every time there's an issue, there's no consultation. You know, you're probably well aware Rosebud, Pine Ridge, and Winnebago had problems. And anyway, and like I said, we were fortunate to have the resources. They took $4.6 million out of our H&C dollars and sent it to pay a contractor without consultation of our tribe. And that's a big problem. They don't consult. They don't share information. They transfer our people out. Like right now, our budget person on our service unit is detailed up to Aberdeen, and we were never consulted. We have questions, and probably very likely he's being paid out of our budget. So there's a lot of problems that's going on. And when I kind of go back, we did have our council passed a resolution asking to eliminate the Aberdeen area office, the Great Plains area office, and send all the funding and authorities down to the local service units. Because right now, one example is a couple years back, I met with our service unit director, and they had like 66 vacancies. And when we get back to my office, one of my staff looks it up on USA Jobs, and out of them, all them vacancies, only 6 were advertised. So the problem is a lot of the biggest problems with the area office. One of the things that patient care, that's something that they have forgotten. Because when I did talk to IHS about this wall, you know, they said, hey, we got to stay in compliance, you know, and so that's their main priority. And one of the things Senator Rounds, you know, he introduced, I guess it's now S498, and I really hope that Congress passes that, and that's doing an audit on IHS. He did kind of a study, and within the study, he found a huge amount of administrative and very little doctors. I mean, that's something that has to be looked at and be dealt with. I mean, we need solutions, and I got 10 seconds, so I'll be really quick. I bought some packets that's really briefly to show you that this is a report that IHS has given to me and given to us, and if you could see the amount of carryover, and when you look through their top priority is to build this wall, and second is dialysis, and third is the treatment. So thank you for the opportunity.
Thank you all for your testimony.
Thank you, Mr. Joyce. But when I read about that wall, it just kind of took me back. And the whole issue on consultation. I appreciate you bringing up broadband. I was able to secure a place on the Agriculture Finance Committee for Appropriations, and one of the things I'm going to talk about is many of the programs that are in there in Indian country also affect the quality of life, health, and safety. So thank you for bringing that up. Part of the other testimony that was in here was when, I mean, unless people really look at a map to see the areas that you gentlemen cover and how close the nearest quote-unquote public hospital is, I don't think people have a full understanding of just the isolation that still exists here in the United States. So one of the points that you brought up was with law enforcement, Mr. Fleinhock, that if you send someone, if law enforcement picks someone up and you take them to a healthcare facility, all the charges and everything that are kind of incurred, and then you have a law enforcement officer that isn't out patrolling the area. Has there been any discussions about better joint powers or mutual aid or anything between the tribal hospitals, clinics, and ERs and the other hospitals and clinics and ERs? And I bring this up because we're all citizens of the United States. We're all taxpayers into the United States, and getting people health care and not going into debt when they're referred or go out of, quote, out of network, off the reservation to receive critical health care if they think they're having a heart attack. In reading some of the testimony, you talk about how all of a sudden people have these large bills and it's causing hardships. If you touch on that. And then diabetes, getting to dialysis. I mean, I know what the winter was like in the Twin Cities. 55 below, 75 below, wind chills. You can't be outside for more than just a few seconds. I mean, people think it's cold here. Well, welcome to the bold north, right? Mm-hmm. So you're not going to get in a car and go to dialysis. Or if you go and, you know, the winds take up, I've been in whiteouts. And we talked about this before. Has there been any conversation that you've been able to engage with the Indian Health Services about working in conjunction to receive either more dialysis within the reservation and maybe opening it up for people who live nearby? I've talked about this before, or vice versa, because I don't see any movement on this, and this is something that I know firsthand from a grandmother who was going from Montana into Williston, North Dakota, and how dangerous it was in the winter to go to dialysis. So if you could just kind of touch on some of those things. I know they're pretty broad, but.
You know, right now, yesterday we talked, and back home we have a lot of snow. I believe two of our schools, well, all of our tribal schools, they averaged, I think, around 14 days of no school because of the snow and because of the cold. But we have 51 dialysis patients that we have to struggle to get out and plow them out, because some of them live out in the communities and even out in the country. So it is really a hardship, and that's interesting. We met with Weaki, And we talked to him about this dialysis, and one of the things he was upfront with, he said IHS does not provide this. But on the Standing Rock Indian Reservation, they do have dialysis in their IHS facility. So it has been done and it can be done. So that's something that we had a discussion with them, but they didn't seem very excited about it. And this is what I want to say overall too. I really found it sad is because we come here not just for healthcare, but education, roads, law enforcement, et cetera. But the top people in these agencies are not here this week. They're on travel. Tony Dearman, we have a meeting with the director. He's not in town. Tara Sweeney's not in town. And also Wiyaki. I mean, we come up here, and they knew that Indians were coming this week for appropriation, and it's sad that they all skipped town. So I guess we're going to have to talk to their secretaries and say hello to janitors. So that's something that they need to really be slapped on the hand about, is that when they come to town for help, you know, let's help them. So.
Yeah, we knew when you were going to be in town.
Yeah.
We'll be seeing all those people later passing on your
Good,
questions.
thank you.
Anyone want to touch on some of the other things that I talked about, law enforcement, and then you've got a Department of Justice bill for putting someone in for treatment or something?
Chairwoman McCullen, I really wanted to, if I could, touch on the broadband. I know because you are on the committee, if I possibly could. Just really quick. And the reason why it's important for our community is because, again, we talk about the services of internet and whatnot within the community. We're located by the city of Maricopa. You would figure we would get some good quality services because Maricopa is the 88th city recognized in Arizona, but we still have our problems in our community. Unfortunately, we see our students that have to come to our admin building or buildings around the community just to get access to Wi-Fi, and sometimes those services are shut off at a certain time, or you don't want them out there 9, 10 o'clock at night when they should be home in bed ready for school the next day. But again, you know, with school having to initiate a lot of you know, after school or homework that you have to have access to some kind of broadband service. It's difficult to get that out there, and you know, it's unfortunate. We see our problems, and and we see it with their grades and whatnot, and incompletion of homework and whatnot. So it's really, really vital and key that we get the best services we can, you know, that we possibly can for our children out there, because it is really hurtful to see that they're struggling in school because of that aspect. And one last thing is that we have an industrial park area in our community where we could be very successful in that area, but because we don't have broadband service or internet connection to the area, it's hard for businesses to come and locate there. But there's an interest, but that's the only detriment to getting it. So thank you.
Thank you. Thank you.
Thank you. It would also be beneficial for what is coming of age is the telemedicine aspect, if you have it, and that I know my wife is a nurse, and so when you ER and late at night, they're sending things to Israel to have the doctors there review them and send them back their report. So it's a way for be more cost effective for everybody, as well as an educational tool and all that's necessary. I just have one problem, Chairman Frazier. As I look at these numbers that you just provided, there's $1 million for the wall and $2 million for backfill around the entire facility.
Yeah. Isn't that just frost your cookies?
Are they backfilling existing premises that were built, or?
You know, I can honestly say they have never consulted with us. So, I mean, they have never consulted with me. And as a tribal nation, they need to come before our entire tribal council, the governing body, to consult with us. And as a matter of fact, they should be doing that at least once a year, but they don't. So I couldn't really say what the backfill was. That might be a good question for Wiyaki when he comes.
Okay.
He's aware of it. He got this report because I gave it to him, and I questioned him on it as well, and he had no idea what it was. So.
Well, it's your property.
Yeah.
Ask before you dig.
Yeah, it's a lot of backfill. Somewhere you got a big hole that needs to be backfilled that you should know about.
Yeah.
Well, thank you all for your time and coming forward today, and appreciate all your input.
Thank you.
Thank you.
Thank you, sir. Thank you. Always good to see you, sir. We have our last panel. Thank you so much. I have short arms. We have our last panel. If they would please come up. And everybody's here. So we're going to hear first from Councilwoman Dr. Monica Mayer. You'd introduce yourself again for the record, and please start your testimony, and we'll let you know when the 5 minutes are over very gently. We've been letting everybody kind of go over about 30 seconds. If you see it red, don't have to hit the panic button.
Okay, thank you. Good morning, Chairman McCollum and the other members of the subcommittee. My name is Dr. Monica Mayer. My Indian name is Hochbadi Sagesh. I'm an enrolled member of the Mandan, Hidatsa, Arikara Nation, or 3 affiliated tribes in western North Dakota. And I am also a family practice physician. I am a fairly well-educated American Indian woman, and have an Associate of Arts in Business Administration and a Bachelor's of Science in Education, and taught high school before I went into medical school at the University of North Dakota School of Medicine InMed program. I have 22 years of clinical experience, all in the Great Plains area. And I worked the ERs for 18 years there, and provided clinic services and hospital care services. Became the Chief Medical Officer for the Aberdeen area, formerly known as the Aberdeen area. And during my tenure there, which was just prior to the Rosebud, Pine Ridge, Winnebago CMS issues, I had visited those facilities and worked them, and came back to let the area office know that if we don't staff immediately the emergency rooms, we're going to have a bad outcome, and they undermined me, and I left. And I did return home, and my mother, who recently passed away, thought I should have my head examined because I ran for office, and now I'm sitting as an elected tribal official, and I think I'm the only, I believe, American Indian woman physician to sit on a council. So I took a significant pay cut, so my mom thought I should have my head examined. But she was just teasing me because it's the spirit of service that is my passion and where my heart lies. So I have a lifetime of experience clinically in the Great Plains area. Although I'm very grateful to Mr. Chairman Fox, my chairman from the MHA Nation, to have asked me to come down to represent him, not only for our nation, MHA, but also for the entire Great Plains based on my experience. And with that, I'd like to say I appreciate the opportunity to testify today, and I'd like to say that when I was the Chief Medical Officer back in 2010 for the Great Plains area, I declared drugs and alcohol as our #1 healthcare issue in Indian country, because if anybody who worked grassroots, whether it be in the schools and the clinics and the ER, anywhere in our society, that you would realize drugs and alcohol is the main issue in healthcare. You can talk about other issues, but the data is hard to grasp on this disease of addictions. And, but I think if we ever did get a significant data, it would prove that we are no different than anybody else in America right now, dealing with not only opioid crisis, meth crisis, but also our alcohol crisis that we have. For it touches everybody in our nation, from the infant that's in utero to a meth-dependent mother, to a child who's been fostered to foster care, to a teenager who can't finish high school because they're drugged out, to an adult who can't hold a job down because they can't pass a urine test because of their addiction. And the poverty level in the Great Plains, our large land-based nations, is astonishing. It's in the 80 percentile in South Dakota, in Pine Ridge, Rosebud, Cheyenne River. Belcourt is like 68%. Fortunately for MHA, we have a lot of oil revenue, so we don't have significant poverty, and we try to make up for that. But also the elders are being abused by younger generational people for the sake of stealing from them just to support their addictions and the cost of opioids. Also, opioids, I could see this coming 20 years ago, this crisis. Any family practice doctor would have seen it. But in Indian country, we only have 50% of our fulfillment need financially. But if you don't have the staff to run those clinics and ERs, you can't generate any third party. So how does the government expect us to make up that balance when we don't have the staff to do it, particularly nurses? I mean, it's a crisis for us because you can't run anything in healthcare without being on the back of a nurse. KDU, hospitals, clinics, ERs, nursing homes. So we are in a drug and alcohol crisis in Indian country. It's huge. And I'm here to say that the MHA Nation built a $25 million without federal or state money treatment facility in Bismarck. We just opened up for services. We need a waiver, an IMD exclusion waiver for the fact that we need more than 16 beds. We need 32 beds for to deal with the crisis. And so, Madam Chair, I'll tied with drug and alcohol. I know my time's running short, but mental health is the dual diagnosis of the disease of addiction carries with it. And also the violence against Indian women is breaking up the fabric of our American Indian country. And so with that, I'd like to conclude by saying thank you for your time. Thank you for listening to me. There's so much more to discuss. And I think that my bullet points would be drug and alcohol, a unified mental health issue with them, more policy and procedure and laws, and meaningful tribal consultation with area offices and DC offices. Staffing needs to be addressed.
I'm sorry, Doctor.
So thank you, Madam Chair, and for listening to me, and hope that we can come to some improvement on the great healthcare disparity that our American Indian families are enduring in the Great Plains. Thank you.
Thank you. Thank you very much. Melanie Forkiller, Senior Policy Analyst of the Choctaw Nation of Oklahoma.
Thank you, Chair McCollum. Thank you, Ranking Member Joyce and members of the committee. I bring greetings from Chief Gary Batten and Assistant Chief Jack Austin Jr. from Choctaw Nation. I'm Melanie Forkiller, and I'm here to present to you the priorities for healthcare for the Choctaw Nation of Oklahoma. The Choctaw Nation is the third largest Native nation in the United States. We comprise over 230,000 citizens across the nation. We're located in extreme southeast Oklahoma, which is about 10 and a half partial or full counties in the southeast corner of Oklahoma, which is fairly remote and the highest poverty rates in the state of Oklahoma. I know earlier today you've heard about the lack of appropriations for 2019 and the effect that it had, particularly on health care, but also on BIA programs related to those that we operate. And I just wanted to add the Choctaw Nation's voice to that in terms of supporting advance appropriations for IHS. IHS and tribal health systems, as you know, were the only direct federal health care program to be affected by the partial government shutdown, and it really made us scramble in terms of how to provide continuity of care for our patients. It put tribes, frankly, in an awkward position of having to determine how to continue to administer these programs while we weren't getting paid. So how were we going to fund continuation of those programs in that interim? And so we certainly want to raise that to your attention. We look to your leadership and support as we go forward this year, and hopefully advance appropriations for IHS can be put on the table and really seriously considered. We appreciate that. We also thank you for your continued support of the joint venture construction program. Particularly in Oklahoma, we have no facilities on the big healthcare construction facilities list, which would take decades, as you know, under current rates of appropriation to complete. So joint venture is really a way for us to leverage both federal dollars and tribal dollars together to make those replacement and new facilities for underserved areas a reality. So one thing, however, that concerns us is that the Indian Health Service hasn't competed this program since 2014. It's very small and very highly competitive, and it's very highly successful as well. And we'd really like to encourage IHS to compete that on a more regular and frequent basis, at least biannually, so that high priority facilities can be addressed with the joint venture program in the future. We do have a number of other healthcare priorities, and we've written about those in our written testimony. I just want to talk about a couple of those to you today while I have the opportunity. One is graduate medical education programs. The Choctaw Nation of Oklahoma, we have a system of 1 hospital and 8 outlying outpatient facilities. We are very taxed, as we all are, with staffing, maintaining staffing for those facilities. Our hospital is relatively small, given as hospitals go. We're in a community of 1,100 people, so it is highly challenging to recruit healthcare professionals to a very, very small community with small schools, no housing, and lack of amenities that health professionals look to when they want to move to a community. So we started a graduate medical education program on our own with HRSA funds back in 2012. We have found that to be the single most effective recruitment retention tool for healthcare professionals for us to stay in our system, because if that, not only do they highly stay within our system, either at an outpatient facility or at our hospital, they will stay in rural Oklahoma and be practicing as our neighbors, which we also need to refer out for care and for, just having the system of healthcare that you need in rural areas. It also has raised the quality of care, we believe, within our entire system, because it causes our docs to be faculty. They have to remain up on all the latest and greatest notions of healthcare and be able to teach that to those residents. It is also a recruitment tool for those docs. They want to be in that kind of learning environment. So our pitch is that we really need to replicate these programs in Indian country and have a steady stream of funding that's reliable for GME in Indian country. So with that, thank you for the opportunity to speak, and I'll be happy to answer any questions you have.
Thank you. Dr. Galbraith, Medical Director of Quality Insurance, South Central Foundation.
Hi, I'm Donna Galbraith. I'm the Donna Galbraith, the Senior Medical Director of Quality Assurance at South Central Foundation. South Central Foundation is an organization that performs healthcare in Alaska. We have 2,300 employees, and we cover health services, including pediatrics, OBGYN, native men's wellness, dental, behavioral health, and substance abuse. We've won the Malcolm Baldrige Quality Award 2 times. We serve 65,000 people, and it's on behalf of these people that I'm speaking. Our service area is Anchorage, the Valley, and numerous rural villages. And it's 100,000 square feet, so square miles. So it's the size of Wyoming. Square feet would be nice. We could do that. Size of Wyoming's a little more difficult. So we're really happy to see that some funding increase for Indian Health Service, but there needs to be more. You know, it's estimated that IHS only funds like 1/5 of what it should. So per capita, it's 1/5 of what is funded throughout the nation. The current administration's comments and actions that seek to undermine the sovereign status of tribes really concerns us. So please reject efforts by the administration to eliminate or cut appropriations to Indian health care programs. I wanted to mention the 105L lease programs. These need to be funded, needs to have increased funds, and we recommend that there be a sub-account in the overall budget so that this gets funded, because right now there's movement to not fund this, and it just doesn't work well when things aren't funded. The other piece is that Indian Health Service has a proposal to repeal the fact that they fund hospitals and clinics. And all of you know that if you don't have hospitals and clinics, you can't provide health care. So that doesn't make sense either. Indian Health Service needs to continue to fund these. So this gets to advanced appropriations for Indian Health Service. Again, you guys are well aware that you need to know where your funding is coming from in order to operate a business effectively. And we never know. We don't know what we're getting. We don't know when it's going to be here. And so that isn't an effective use of resources. So what we do is we actually hold some funds in reserves, which isn't effective either. I mean, it works. It's effective for us, and it's effective because we have those shortfalls and because we have the delays in funding. And so that's how we handle that. But those funds could be going into healthcare if we knew when we were going to get the funds from Indian Health Service. So having appropriations that are set is really important in order to effectively deliver healthcare. Otherwise, it affects the quality. Behavioral health programs are also extremely important. You know, there's lots of substance abuse, addiction, and suicide. You've heard a lot about that today. Alaska has the highest overdose rate in 2015, and we've had a marked increase in death because of this, a 500% increase in death. You guys all know the statistics, and you've heard this from many people, but you have to realize that, you know, some of our communities are really small, and you have one suicide in the community, it affects everybody. Not just that family, but everybody in the community, and it reverberates because, you know, we are all connected to one another. Even people living in cities are affected by that, so the impact is incredible. Increased funding for substance abuse is really important, above and what's been increased for 2019. The opioid crisis is real, and you know that. I know you know that because you've tried to address that. But, you know, if you look at the Indian Health Service shortfall in money, and you add the opioid crisis on top of that, it doesn't work very well. It makes the shortfall even greater than what it really is. We really need those funds to get to our youth. You know, this will, if we can have positive impact on our youth and get at the root causes of substance abuse and behavioral health issues, then we can actually have an impact. We have a program called the Pathway Home, and we've served over 1,100 youth in the state of Alaska, and it's great to see them when they graduate because they're so proud. Most of them get their high school diploma through that program, and it's really wonderful to see. I also have to mention contract support costs. I know that there's an indefinite appropriation right now, and I think that's really good, but IHS has made this a very complicated process. It was already complicated, but they've complicated more by having increased documentation requirements, and they require 2 appropriations a year to occur. So it's become really complex. So if you could ask Indian Health Service to actually make it simpler to use and user-friendly, that would be really appropriate. Thank you for your time. You know, the Indian Health Service and all the things in healthcare, it's a vast network, and everything is connected to one another. So if you decrease money over here, then it has an impact over here. And that's what Indian Health Service is doing, shifting pots of money. And so overall, it needs to increase so it's a more functional system. So thank you for your time, and thank you for letting me testify.
Thank you. Dr. Bell, American Academy of Pediatrics Committee on Native American Child Health. I don't think we've had someone so focused on the next generation before. Welcome.
Thank you. I'd like to start by recognizing that we're on Indigenous lands as we speak, and thank the people who've come before me that allow me to be here. Thank you, Chair McCollum and Ranking Member Joyce and subcommittee members. As you mentioned, my name is Dr. Shaquita Bell. I'm Cherokee. I am here today on behalf of the American Academy of Pediatrics, and I'm a practicing pediatrician in Seattle, Washington, but born and raised in Minnesota. And I'm, as you mentioned, the chair of the AAP's Committee on Native American Child Health. I have the privilege of working with groups like the Seattle Indian Health Board, Puyallup, and Tulalip tribes. And through that work, I see firsthand how Native children's health can be improved by addressing disparities. I'm currently caring for a child who's enrolled in a tribe, and we were able to offer wraparound services through the tribe, through the schools, and through the healthcare system to address her needs in while being in the foster care system. So this is really important to me. As many of the folks who have spoken today, I think we've covered the fiscal environment really well, but I'll add my 2 cents. We appreciate that Congress was recently able to provide the IHS with $5.8 billion for fiscal year 2019, which is an increase, as you know. But we also know that it still really leaves a substantial unmet need. The Broken Promises report from the U.S. Commission on Civil Rights really addresses this well and highlights the significant disparity in per capita spending and some of the unique challenges that creates. IHS needs stronger funding and budget certainty. During the most recent shutdown, I actually reached out to fellow pediatricians and heard about places that were running out of really simple but basic health needs like neonatal oxygen monitoring devices, medications. We had providers who weren't sure if they were going to be able to winterize their house. It was very devastating, the shutdown was. So I appreciate that your bipartisan bill for advanced appropriations, and we really hope that greater budget certainty would also be able to enable IHS to recruit better and to retain better pediatric health care providers. As we've heard earlier from Winnebago and from Ms. Forkiller, that education is really important, and I have the privilege of working with many Native students through the University of Washington. And student loan debt is a major impact on their career decision. We strongly appreciate the value of IHS Health Professions Scholarship Program and Health Professions Loan Repayment Program, which are key tools for recruiting, but we urge you to consider fully supporting these programs by allowing them tax exemption and to help cultivate the continuity of care that Native children need. Given Native children's unique health needs, we are heartened that IHS is currently in the process of hiring a maternal child health coordinator. This role is really key and has been empty for 6 years. This role is essential in identifying and replicating successes and model programs in maternal child health programs, and we urge the subcommittee to ensure timely hiring of a talented professional for this role. I often see firsthand the struggles of parents who are experiencing addiction and substance use disorder, and I have the privilege of working with those families in my own clinical practice. Currently, I am helping a mom who was addicted to heroin and cocaine early in pregnancy. She had the ability to access appropriate care and is now in a medication-assisted therapy program, and her child is now 15 months old and is developing wonderfully and beautifully, and those services were so crucial for his development and for her to be present as his mother. I'm also really touched by the SIHB's report on missing and murdered Indigenous women, and it's really sparked inspiration for me to do work on trafficking in children in Seattle and in the hospitals there. Wherever we travel across the country and everything you've heard today, there's a consistent theme that there are challenges everywhere, but there are also really dedicated and powerful people working on this, like this wonderful slate of women that I have the privilege of sitting next to. And I think it really demonstrates that there are people with passion here, and that flip too soon. Any of the children that we have the pleasure of serving may one day be able to take our place here, and that's ultimately my goal. I thank you again for the opportunity to be here, and I'm thankful to all of the people who have come before me and will come after me in the next 2 days. Thank you.
Thank you. Mr. Joyce?
Well, thank you. And I realize as the co-chair of the nursing caucus how tough it is to find and recruit people everywhere in these, let alone or you're not sure of your funding source day to day, or the other issues that you have along with it. Certainly open for any ideas on how you can try to promote that. But I believe that nurses are the next generation of primary care physicians. I mean, obviously we don't have enough of those either. And certainly if there's ways that we can promote that in either through loan repayments or those type of things to help bring medical professionals on, because sometimes dollars aren't going to be enough. You get not competitive, unfortunately, in the workplace, so you need to do everything you can to bring people together. I used it effectively in my time as a prosecutor to get young kids on the fact that they're going to get some loan forgiveness out of this, and just when you got them properly trained, they left because they got their time in under the loan forgiveness program. But at least you had the chance to bring them there for that period of time and use them. So certainly open to any ideas or suggestions you have on how we can continue to feed the process for your medical professionals. Thank you.
Thank you. I was very saddened to hear that the maternal child health coordinator position had been empty for so long. And like you, I think that that's an important position to have filled, but filled with the right person as well. Dr. Galbraith, you mentioned the behavioral, special behavioral pilot program, similar to special diabetes program, so it's culturally appropriate. If you have more information on that or can direct our staff where we can look more to learn more about that, I would be indebted for you to do that as well. Dr. Bell, like maybe if when we talk to Indian Health Services about filling the maternal child health coordinator, what some of the talents that you think that individual would need. I want to thank you, Ms. Forkiller, for bringing up how, giving people an opportunity to live and become part of a community through loan forgiveness can really be impactful, even if they don't stay working at your hospital. If they're at a hospital nearby, you have someone who's been culturally aware, if there's a referral out, and also a person in the community who understands a little better the journey that our tribal brothers and sisters are still going through in this country. So thank you for your workforce. And we do read the full testimony. I'm going to prove it to you, Dr. Meyer. I am very interested in what's going on with the oil and gas revenues in your state. And I will bring that up in the next, at the appropriate panel on that. So we do read the full testimony. So I can't thank you, everybody who's been here, enough for being here. And as you pointed out, all my sisters who are here testifying today, and then we're ending with a fully empowered woman panel with a woman leading the staff and me being the chair. We have good brothers out there. We love our brothers, but we have to celebrate our successes when we see them. And for our daughters, your daughters, to my brothers, to see women in leadership is something that every parent, when they hold their child, no matter what gender, wishes for them health, happiness, education, and opportunity. So thank you for being here to voice that, and we would appreciate your feedback. We were able to drill down a little more on healthcare. Mr. Joyce, we have our homework cut out for us. You and I need to talk to Mr. Yarmouth and Mr. Womack to get the ball rolling on advanced appropriations, or talk to our partners on the tax committee about making mandatory appropriations with Mr. Cole. So I think we should have our staff maybe do a pre-meeting with the budget staff about this, and then you and I need to entice them with coffee or something. We'll find out what their beverage of choice is, to have a serious discussion. It took the VA, when they nurtured out this idea, it took them years to develop. I'm not saying we'll get it done this year, and maybe mandatory appropriation would be the other alternative to go, but we have to do something in the interim, because we said you were protected during sequestration. Everybody thought nobody's going to cut Indian health care. We're okay, only to find out with sequestration, when we heard back from the administration, their hands were tied. They were over the top that they couldn't do anything. So were members of Congress. Then it's, a shutdown. and it happens again. And it cannot keep happening. This cannot be the only place in America where American citizens who have, under treaty rights, been promised their health care, not have it available to them. And we know that people suffered, and we probably know that people suffered irreparable harm, and there were probably people who passed away because of this. And you have my pledge, I know, as well as every member on this committee, both Republican and Democrat on this committee, to be a forceful voice that this never happen again. So thank everyone for testifying. We will stand in recess until 1 o'clock. If, just for the record here, we know we have a series of votes coming around 1:15, 1:30. Our apologies, if Mr. Joyce and I control the world, that would not happen, but we're not in charge of the floor of the House. So thank you, everybody. We're in recess. I'm going to walk over to the attorney physician's office. I have to follow up on some lab work I did not follow up on. And I tried to do it this morning, but the person that could do that wasn't there this morning before things got started.
And I did reach out to IHS yesterday, I think it was, about the status of the filling the maternal health